Hello, everyone, and welcome back to day 2 of our National Fall Symposium. I hope that all of you who were able to join us last evening enjoyed our sessions and left the evening feeling inspired. I know that I sure did. If you didn't join us yesterday, welcome. You're in for another great evening tonight. If you don't mind, I'd love to know where everybody's from tonight. If you can put in the chat where you're joining us from. I would once again like to acknowledge the Indigenous peoples of all the lands that we are on today. While we are gathering virtually, let's take a moment to appreciate the importance of the lands we each call home and to reaffirm our commitment and our responsibility in improving relationships between nations, as well as our own understanding of Indigenous peoples and their cultures. Thank you again to those of you who joined us yesterday and those of you who are tuning in now for the first time. Events like this are made possible thanks to the support from our fabulous community. And I'd like to once again thank our sponsor, GSK. I'm excited to say that we have over 500 people registered for our event, all the way from coast to coast. We have people from Courtenay, British Columbia to Prince Edward Island and New Brunswick and everywhere in between. So welcome. A few housekeeping items before we start the session tonight. Just a reminder that we are recording everything this evening and that the recordings will be available on our website. So please feel free to rewatch if you found a session you loved and maybe you missed some things, go back and rewatch, share it out with family and friends who were unable to attend. And also remember that we have saved some time at the end of each session tonight for your questions. So at the bottom of your screen, you will see a little icon with Q&A, the question and answer. It's so easy for us if you pop your questions in there, and we will make sure to get those to the speakers for the end of each session. I also just wanted to remind you that we won't be able to answer questions about your individual cases at this event tonight. But definitely put in any more general questions and we're happy to forward those on to the speakers. If you do have questions that are specific to your own individual case, we would encourage you to talk to your healthcare team about that. So without further ado, we'll begin. I would like to introduce Alison Ross, the Director of Knowledge Mobilization with Ovarian Cancer Canada, who will be facilitating our first 2 sessions this evening. Welcome, Alison.
Thanks, Steph. Thanks. So recurrence is a topic that comes up frequently in conversations with women living with ovarian cancer. So in this next session, Dr. Leslie Roberts, gynecological oncologist at Cancer Care Manitoba, will be joined by Teal's sister, Terry McGraw, who will share her knowledge, lived experiences, and tips to manage recurrence. Terry lives in Winnipeg and loves spending time with her family and friends. She is a nurse by profession, and she's looking forward to navigating this difficult subject of recurrence in the journey of living with ovarian cancer. So over to you both.
Thank you very much. Just give me one moment. I'm going to share my screen, and hopefully that is now visible for everyone. So the way we decided to structure this is that I'm going to give a very short little talk about recurrence from the gyne-oncology perspective and what we think it's important for people to know. And then Terry and I are just going to kind of chat about questions that have occurred to her and to other people who are in similar situations. And then hopefully we'll leave enough time at the end that anyone in the audience can ask questions. So I'm sure this is going to be news to absolutely no one, but I think it's important when we're talking about recurrence to just have a little bit of background about ovarian cancer in general. So there are multiple types of ovarian cancer, and I'm sure not everyone on this call has the same type of ovarian cancer. Most of what we talk about when we talk about ovarian cancer, and most of what I'm going to be talking about, is what we call high-grade serous ovarian cancer, which is the most common subtype, but there are differences depending upon what particular type of ovarian cancer you may have. Typically, ovarian cancer is going to present with an advanced disease. So that's what we call stage 3 or higher. And the overall 5-year survival, which is what most oncologists use when we talk about survival, that varies by stage. But we know, generally speaking, that the rate of survival, so your overall likelihood of survival, is going to decrease as your stage advances. And as a result, we know that the rates of recurrence end up being quite high for ovarian cancer. So it can be up to 80% in advanced stage ovarian cancer, again, depending upon the stage that you have and the particular type of ovarian cancer you have. But it's quite common. So I think this is a very important topic to discuss because it is so common. So before we get into it too far, I wanted to present a little bit of a glossary of terms. Now, these are not specific, and I apologize if you can hear mumbling in the background. I'm still at the hospital and they call codes every once in a while. But generally speaking, I've had a lot of people talk to me, a lot of my patients talk to me about, why don't I use the word remission? They want to hear that word. It's important to them. It's not a word that we typically use in ovarian cancer. You are going to hear very few gynae oncologists use the word remission to define where you are in your disease. What it means is that there's no evidence of any active cancer. So any scans or tests or anything like that do not identify cancer, but it implies that there's the expectation that your cancer is going to return at some point. Remission implies kind of a break, but it's going to come back. And the reason we don't commonly use it in ovarian cancer is because the primary treatment, the treatment that you get when you first get diagnosed, that treatment is curative in intent. We are hoping that this cancer never comes back. We know that it might, but the goal is for cure, and therefore we don't tend to use the word remission. Words that you may hear instead are no evidence of disease, which means that we looked with scans, we've done exams, we've done blood work, and there's no active cancer to be found. This is often something that we talk about also after surgery, when we've been in the belly and there's nothing left that's visible. Or people might use the phrase cancer-free, which means there's no evidence of any active cancer on imaging, clinical examination, or blood work. And this is usually what we'll talk about post-primary treatment when we're still aiming for a cure. The problem with a cure is that I cannot tell a patient that they've been cured until they've proven to me that they are, which means they've gone 5 years with no evidence of any disease coming back. So it's kind of difficult to tell someone up front that they're cured because I won't know that for 5 years still. So we use the phrase cancer-free. But what specifically is recurrence? And this can be tricky sometimes to understand. So from an oncology perspective, from a physician perspective, recurrence is evidence of active cancer following a period of time with no evidence of disease. So you managed to have negative CT scan, normal CA-125, clinically well for however long that may be. That could be a month, that could be 5 years, and then the cancer comes back. That would be a recurrence. That's different from progression, which is evidence of growth of cancer that we know is there, either on or off treatment. So some women will stop chemotherapy because they've gotten a maximal response, so there's no more shrinking of disease. Or we don't see any disease on CT scan, but a CA-125 is still a little bit elevated, which makes us think, well, maybe there's something there, but we're not getting anything more other than more side effects with chemo. And so we stop. If that were to develop further, if the CA-125 were to rise or you were to get symptoms, that would be considered more of a progression than a recurrence because there was never any true cancer-free time. So those are the phrases or the words and what we mean by them when we talk about recurrence. And this talk was sort of geared towards, in general, how we monitor for recurrence. So this is mostly for the patient who's done treatment, who is currently off treatment. What are we doing now? How are we monitoring? So in Canada, the recommended mode of monitoring for recurrence is clinical. And what that means is that there will be a symptom assessment. So someone will ask you a whole bunch of questions. That can be a nurse, that can be a physician, and there will be a physical examination, typically checking your abdomen, doing a pelvic exam, looking for any concerning symptoms or findings. And that will usually occur every 3 months, although as you get farther away from your initial treatment, those visits may be spaced out. If there's any concerning findings on the symptom assessment or exam, that is when we would move towards doing some investigations, typically a CT scan or blood work. Usually, in most centers across the country, there will not be routine CT scans done with every visit. That's pretty uncommon, and it would be fairly specific situations in which you would be getting, say, an every 3 month CT scan. CA-125 is a little bit different. That varies very much across the country. It varies based on what type of cancer you have, what the particular nuances of your cancer were. So CA-125 standardized is a little bit trickier, but we are going to talk about it because it is something that people ask about fairly frequently. So CA-125 monitoring, what is the evidence for doing it? Or as I say, the lack thereof, because there isn't really an awful lot. So in Canada, the guidelines that physicians follow for monitoring ovarian cancer recommend against routine CA-125. So they say, do not do this every 3 months, every time you see a patient. In Europe, they also recommend against doing a routine CA-125. In the US, they say you can consider it to monitor for recurrence in discussion with a patient. And as most of us know, the US tends to be a little bit more intervention forward. They do a lot more with perhaps less indication. It's a different style of healthcare practice. But what actually is the CA-125? Why do we care about it? Well, it's what we call a tumor marker, which means it's a protein that's found in the bloodstream that tends to be elevated when you have a cancer. So 80% of ovarian cancers will be associated with an elevated CA-125, not all of them. However, the tricky thing with an elevated CA-125 is it's not necessarily only caused by ovarian cancer. It can be, but it can also be caused by having your period, by having intra-abdominal infection or inflammation, if you have liver failure, if you have heart failure, a whole bunch of things can cause this. We've been seeing over the past 2 years a lot of elevated CA-125s with people who get COVID, for instance. It's been throwing off our numbers quite significantly. So it's not a great test. It's what we have, but it's not a great test. So the evidence, the scientific evidence behind this originally started in the 1990s, where primarily in Europe, they did some trials and they found that the CA-125 rises about 2 to 5 months before clinical signs or symptoms of a recurrence. So you would be asymptomatic, they would find an elevated CA-125, and then they actually watched to see what would happen. And several months later, it would be found that someone had a recurrence. And they noted that you needed to double the upper limit of normal. So depending upon your lab, that is slightly different, but it usually lands somewhere between 30 to 40 is the upper limit of normal for a CA-125 value. And in order to accurately predict a recurrence, that would have to go up to double that. So 60 to 70 in that range. A little tiny bump was not accurate in terms of predicting recurrence. So that's also important to keep in mind when we're thinking about CA-125 and how we interpret it. In 2010, there was what we call a landmark trial, which means that it was a very important trial that actually changed practice. And it was a randomized clinical trial, which is the best type of scientific evidence we can have. It looked at 529 women with ovarian cancer, and they had CA-125 monitoring following completion of their treatment. So they had no cancer, active disease, and they were just having this CA-125. There were 2 groups. The first group, as soon as that CA-125 started to go up, they started chemotherapy. The second group, the CA-125 went up and they delayed the start of any chemotherapy until they developed symptoms. So they waited, they didn't start with that CA-125 value. They started when they had symptoms of recurrence. And they found that there was absolutely no difference in survival between the early group and the late group. So it didn't seem to matter in terms of how you did from an overall cancer standpoint, whether you started right away or whether you started later. But what they did notice was that women reported that their quality of life was worse when they had the early treatment start. So when they started as soon as that CA-125 result went up. And on the basis of this, most physicians think that the CA-125 is not helpful because figuring out that you have a recurrence early doesn't seem to change your survival, but it does seem to make people overall have a worse life. And that's not what we're going for. We obviously want people to live as long as possible, but we also want them to live as well as possible. So the impact of early diagnosis of recurrence is basically that there isn't one, honestly. So there's no survival benefit seen with an early diagnosis and treatment of recurrence. So when I say early, I mean prior to developing symptoms. There's no benefit. There's no improvement in what we call progression-free survival, which is different than overall survival. Progression-free survival is essentially the time where you're cancer-free. So it's basically the time between when your cancer treatment ends and when the cancer comes back, if it's going to. That also didn't change whether you started your chemotherapy immediately upon a CA-125 rise or later. But again, we know that the quality of life decreases with early diagnosis and treatment of recurrence. So what is the CA-125 actually useful for? Well, it's great for helping us diagnose an ovarian cancer. If you present with a pelvic mass or all of the ascites fluid, a CA-125 is useful in telling us where that might be coming from. And if you had an initial CA-125 rise with your diagnosis, we can use it to monitor response to treatment. But it's not very good for monitoring for recurrence. That's essentially the bottom line here. The timing of your treatment, when you start treatment for recurrent disease, is also something that gets talked about a lot. So the timing of treatment, I'm going to put in a caveat here, it's very subjective and it varies with every patient. Every doctor-patient relationship is going to have a different rationale for timing. However, there is no survival benefit associated with starting treatment early prior to developing symptoms. You do want to initiate treatment typically with the development of symptoms because A, you're going to make someone feel better, and B, if you wait really long, like if you let symptoms grumble and grumble and grumble and grumble, it's possible a person could get too sick to get chemotherapy. So usually we don't want to give people chemotherapy or any treatment when they're feeling well and have absolutely no symptoms. But once they start getting those symptoms, we would stop. So those can include abdominal symptoms, respiratory symptoms. And I also talk to all of my patients about the fact that anxiety around the fact that you may have cancer or that you know you have cancer and we're not doing anything about it, if that's significantly limiting to you, that counts to me anyways as a reason to start treatment. So one of the questions I can ask is, what follow-up can you expect? This was one of the questions that I was asked to answer. And again, this is going to vary significantly across the country. I can't tell you exactly what your oncologist is going to do. What I'm going to talk about is a general model, overall what you should expect. So typically, as I said, you're going to have a routine physician or nurse practitioner assessment every 3 months, and that will include a history of any symptoms that you might have and a physical exam, ideally involving a pelvic exam. Now, I recognize that this has changed in COVID. We are doing in Manitoba, we're doing a lot of virtual visits, and I suspect that that's true other places as well. And they've actually done studies in the US throughout the past 2 years over COVID to see, have outcomes from ovarian cancer gone down with this switch to virtual visits? Are we missing recurrences? And it turns out we're not. So we're certainly not providing any worse care because we're doing this. The ideal is to do a physical exam, but we do seem to be able to safely get away from it, at least in times of pandemics. Investigations with blood work and imaging will be done if there's any concerning symptoms or physical examination findings, but typically routine scans and blood work are not going to be done in follow-up unless there's a specific indication. Now, as I said, that can vary. Different centers are going to do things slightly differently, but by and large, routine CT scans and CA-125s are not going to be done in follow-up, because as we discussed earlier, it does not seem to improve survival and it does seem to decrease quality of life. And that is what I have from a more sort of educational standpoint. And we're going to move into the conversation part, and I'm going to try and figure out how to stop sharing my screen so you can see Terry and myself on the screen.
Thank you, Dr. Roberts. Before I ask my first question, I'm just going to tell you a little bit about myself. I'm Terry McGraw, and I was first diagnosed with ovarian cancer and had my surgery in April of 2021, stage 3B, mixed cell type. I had 6 rounds of chemo like everyone else, did well with all of that. And at 3 months, I had a couple of symptoms, was given a CT scan, which did come back, no evidence of disease. I worked towards going back to work. At 9 months, had another CT scan because I'd had a couple of symptoms. And unfortunately, this one came back showing that I was in a recurrence. Completely new world for me. I had really no idea how to navigate. And so that's kind of where I'm at right now, going through treatment and still trying to figure this out, but also encouraged that I have met women like Crystal and some others who are living quite well with ovarian cancer. And so having a recurrence, as hard as it is, doesn't mean it's the end. So that's one of the reasons why I'm excited to be here tonight to kind of navigate this. So one of my first questions is, Dr. Roberts, when we have mild symptoms, at what point in time should we be contacting our healthcare team? We don't want to be constantly thinking about it and constantly calling our staff. So when should we?
That's an excellent question, and I get asked that question a lot. And what I typically tell people, there's no right or wrong answer. So if you are very worried and you're perseverating, call, right? It's always better if this is weighing on you to call and ask someone. And we are here to support you. People often express this idea that they're worried about contacting the healthcare team too much. That's not a thing. We're okay. It's fine. Call us as often as you need. But in terms of when to be worried, what I typically tell people is any symptom that's new that you haven't had before, that's persistent and gradually increasing over 2 to 3 weeks, is something that your healthcare team should know about. And that can be any symptom, because ovarian cancer can come back anywhere. But the bottom line is that it's not something that's there for a day and then goes away, because everyone's going to have a day where you ate something you shouldn't have and your bowels feel kind of yucky and you get bloated. And if you have a history of ovarian cancer, that twigs something for you, right? And then it goes away again. So you want something that's progressive and present for a while before you contact.
That I've been advised that as well. And one of the things that I do is keep a journal of the dates that I have symptoms, so that when I do call the doctor, I know exactly when they started and how long they've been going on. So if a recurrence is diagnosed, how do we decide when to start treatment? And I guess I'm thinking diagnosed, I would imagine, based on symptoms, since we don't routinely do CA-125s. And sometimes there's more than one treatment option. So how do we decide which to do? What do we ask our doctors about that?
Also, excellent question. So again, this is going to be different for every patient, and it's an individual discussion. But overall, the goal of recurrent treatment is to improve. I mean, ultimately, we want you to live as long as you possibly can, but really the goal of recurrent treatment is to make you live with your cancer as well as you possibly can. So if you feel like you are coping and the symptoms are mild, and you had a really hard time with chemotherapy the first time around, for instance, like it just made you feel really unwell, then typically I suggest to people that they delay. If, however, the symptoms from your recurrence are really bothersome, whether that's thinking about the recurrence and worrying about the recurrence, or whether that's actually physical symptoms, that's when I tell people to go on treatment. As you say, there's lots of different treatments, and what treatment is recommended often will depend upon the time between when you finished your last treatment and when you recurred. We have a 6-month mark that we use a lot in oncology that guides what treatments we're going to use, but most of the time it's going to be a chemotherapy option that we recommend.
Okay, and based on your talk earlier, it sounds like if we do decide to delay for a little while because our symptoms aren't severe, it doesn't actually affect our overall survival. Is that right?
That is absolutely correct.
Okay. Now, if our second line treatment results in a reduction of the disease, but we don't come to a complete no evidence of disease, how do we decide at that point whether we should continue treatment or we should take a break? And then when should we resume?
Excellent question. So ideally, if someone is tolerating chemotherapy, they're doing well. I mean, I recognize that chemotherapy is not pleasant, but if you're having a bad week and then the rest of the time you're doing okay, we typically recommend treating to what we call maximum response, which essentially means treating to the point at which we're no longer seeing any decrease in CA-125 or shrinking on a CT scan. So when we get to a point where your CT scan, say post cycle 6, is exactly the same as your CT scan post cycle 9, that's what we would consider maximum response. Nothing's changing anymore. Now, the cancer is still presumably responsive to the chemotherapy because it's not growing, but it's not changing anymore. So at that point, we will often consider stopping treatment for a little while. And that will usually be what we call a treatment break, because we anticipate if there's still cancer there, we know that off treatment, eventually it will start to grow again. That's unfortunately what cancer does. Without any treatment, it grows. So a treatment break, a standard length of treatment break, is going to be about 3 months, because as I'm sure many of you have noticed, oncologists really love groups of 3. It's our magic number. And so usually we'll reassess at 3 months. If you're still feeling well at 3 months, we'll go another 3 months. But then once you start to develop those symptoms again, once you notice the cancer growing, that things aren't feeling right anymore, whether that's 1 month after stopping or whether that's 12 months after stopping, that's when we would consider restarting treatment again.
Okay. I guess what questions should we be asking our oncologists at this point to help us decide how to move forward? I mean, in terms of, I guess, about our disease itself, what should we be asking?
That's a good question. I think it's always important to ask what happens if you take treatment and what happens if you don't take treatment. I think those are two very good questions. And I find a lot of people don't ask the what happens without treatment, or at least without treatment right now question. I think people often feel pressured perhaps by the oncologist into starting chemotherapy when they might otherwise not. So asking, what to expect with treatment right now versus what happens if I wait, I think that's a very important question to ask. And then being upfront, particularly if you're finding chemotherapy really hard, asking, can I stop? What happens if I stop now? Is there an opportunity to take a break?
Okay, that's helpful. Thank you. If we wanted to seek or pursue some alternative therapies, along with continuing our relationship with our gynae oncologist, is there a way that we can do this in cooperation? It doesn't seem very easy in Manitoba.
Yes, it's not very easy in Manitoba. You're correct. So there's a little bit of a hard line in terms of when you're on chemotherapy. A lot of the alternative treatments that are medication or supplement based will interact with chemotherapy. So common ones that we see are vitamin C and mistletoe are often used, and those actually interact with chemotherapy in a way that makes the chemotherapy less effective. And so we will often ask people to not use those particular alternative treatments while on chemotherapy, because if we're going to use chemotherapy with all of the risks and the side effects associated with it, we want it to be maximally effective. Now, outside of that, and I cannot speak for all providers, but outside of being on active treatment, I am happy to continue to see people and support people and symptom manage if they're on alternative treatments, but I don't personally have the expertise in them. And that's going to be true, I suspect, of most oncologists. Western medicine does not train us in naturopathy and homeopathic medicines and things like this. We just don't have the knowledge. So certainly seeking that out yourself and seeing someone and working with them, I have no problem with that. It's always very helpful if you let your oncologist know what alternative treatments you are using. Sometimes I find that doesn't happen. Like that discussion perhaps is not as open as it should be. So that discussion I think is very important. But unfortunately, based on the way our medical system is built in terms of supplements and homeopathic and naturopathic treatments, most of those are going to be patient-led. Some alternative treatments in terms of symptom management, like physiotherapy, acupuncture, things like this, referrals can be written by your oncologist for those services. And depending upon your insurance, that helps get coverage and things like this. And we're very happy to be involved in that aspect of things. It's not that we don't want to be involved in naturopathy. We just don't know anything about it, really, is the honest answer to that question.
Okay, thank you. I appreciate that. Now, this last couple of questions are a little bit harder, I guess, to think about. At what time should we be expected to be asked or start thinking about a do not resuscitation order on ourselves?
So working in oncology, I think I probably have a very different approach to this than most. I think everyone at every point should think about what their goals of care are, regardless of whether you have cancer or not, and should document those. I have pestered my parents more than you can possibly believe to tell me what their goals of care are, and neither of them have cancer. So that's my bias. I think everyone should be having that discussion, regardless of where you are in your cancer journey. In terms of when you can expect to be asked by your physician about that, most of the time that's going to be at the time of recurrence. Maybe not your first visit, because there's a lot of information at that first visit, but somewhere in that initial treatment of recurrence, you can expect an oncologist or a member of the team to ask you about what your goals of care are. part of the reason for that is because we know that ovarian cancer is essentially, once it's recurred, it's like a chronic disease. It's not going to go away. You're going to live with your ovarian cancer, and you may live very well and for a very long time with your ovarian cancer, but you're going to live with it. It's going to flare up. It's going to go away. It's a part of your life. And in that setting, when we know we can't cure it, we can't make it go away permanently, most of us want to bring up the conversation of, if you got really sick with a cancer that is going to be with you now forever, what do you want us to do? There's no right or wrong answer. That is a personal decision for sure, but that's usually about when we would bring it up.
So in terms of planning, maybe advanced care directives or advanced healthcare directives, how are there supports available to help us to do that? Because we don't all understand all the terminology, or what should happen if I have a heart attack as opposed to have a flare up of a cancer situation, which could have different outcomes. So, yeah.
So this is something that's a bit difficult for me to answer, because advanced care directives and goals of care and how that's done varies significantly province by province and hospital by hospital. But broadly speaking, yes, there's going to be resources wherever you are. Social work is often a good resource. Most cancer care is going to have, whether it's psychosocial oncology or a pure social worker, will have that available. Most cancer care centers also will have essentially a booklet or a guide that's supposed to help guide a patient through advanced care planning. And I encourage you to ask your oncologist if they have something like that. And if so, can you have a copy of it? I know we have one in Manitoba. I've worked in other places across the country which also have them. So I think that's reasonably standard. It might not be cancer specific, but it would be hospital specific or province specific. And certainly if you feel like you're struggling, or you don't understand the terms, or you want a little bit more information about it, just ask for something like that.
Okay. This particular question has been kind of on my mind some, and I know as a nurse, it's a good thing to think about, and that everybody, whether you're healthy or not healthy, should be doing it. But sometimes having had a diagnosis, it feels a little bit different. And so thank you for that guideline. It does help. Making these plans does not make us die faster. We're all going to someday. It just helps maybe give us a little bit of peace of mind knowing that our family knows what we want.
Exactly.
So I actually don't have any more questions for you, Dr. Roberts. And I see that we still have some more time. So Allison?
Yes, I'm here. So thank you both for addressing these really common and these really difficult questions about recurrence. We actually have a lot of questions from the audience coming in, and I just want to set some expectations. We're not going to be able to get to all of the questions. We're going to do our best to kind of group some themes together, and then we can also follow up and try to get more questions answered and get you all that information. So one question I was hoping we could get answered is symptoms to watch for. Are they unique and specific to the individual, or generic for most types of ovarian cancer?
So I would say, broadly speaking, they're fairly generic. Most commonly we see, similar to the presentation, sort of vague abdominal symptoms. So increased bloating, lack of appetite, changes to the bowels, whether that's increasing diarrhea or increasing constipation, sometimes some vague abdominal pain. That's probably the most common. Now, that's not everyone. Some people will have very different and unusual symptoms, which is why I tell people anything that's new and different, let us know. But the most common would be the abdominal symptoms.
Okay. So kind of knowing your body best and what's normal for you, and then flagging those abdominal symptoms. Okay.
Yeah.
Another question, and this came up in the chat, and this comes up a lot in our other events. Why isn't there CA-125 monitoring for those who have a family history of ovarian cancer, given how sneaky this disease is and the lack of other clear symptoms/signals?
That is an absolutely excellent question. And I want to say maybe 15 or 20 years ago, the oncology community was very, very, very hopeful that CA-125 would be a good way of monitoring. And they've actually done huge, huge studies, like thousands of women, both in the UK and the US, looking to see if routine ultrasound scans, routine physical exams, routine CA-125s, if these could catch ovarian cancer early. And very, very sadly, they cannot. There is no effective way to screen for ovarian cancer. They took women, they had them do CA-125s every 6 months for years. It did not change the number of ovarian cancer diagnoses, and it did not cause them to be diagnosed at an earlier stage. It made fundamentally no difference, which is sad because it would be a very easy way to screen, but unfortunately it doesn't work.
Okay, thanks for that. There seems to just be a little bit of confusion around why delaying treatment does not affect outcomes in the recurrence. Is there any way you could clarify that in a bit more detail for people?
Sure, I can certainly try. So this is only true, I'm going to put this out there. This is only true in the recurrent setting. So in the primary setting, deferring treatment definitely affects outcomes. In the recurrent setting, as we were talking about, it's a little bit different. We don't anticipate that we're going to be able to get rid of the cancer permanently. We by and large, once a cancer has recurred, and this is true of every cancer, we've lost our ability to cure that cancer. We can treat it, we can improve quality of life, we can prolong life, but we are unlikely to ever cure it. And so in that situation, when we are no longer aggressively going for cure, we know that it's fine to live with the cancer. You can live with the cancer, and as long as it's not causing you significant symptoms, it's not going to make you die any faster from your cancer. If you never treated it, obviously that's very different. But if you're planning at some point to start treatment, but right now you feel great, or right now you have a vacation that you really want to go on, or something else life important and you want to bump it to later, your cancer will respond the same if you treat it on the day you're diagnosed as if you treat it 6 months later. The only difference potentially is that you might not be as strong if you've been living with your cancer for 6 months without any treatment. So that's the balance there.
So that's really helpful. Thank you. One of the questions is, why is there such a high rate of recurrence?
That is a tricky question to answer. The problem with ovarian cancer, specifically high-grade serous ovarian cancer, is that it spreads what we call peritoneally, which means that it doesn't just start as a blob and grow as one blob, so you get a big lump in only one place. It starts as a very small little tumor in the ovary, and then it starts sprinkling cells all over the lining of the abdomen and the bowels and any other organs that are in your abdomen. And so you get these tiny little deposits absolutely everywhere throughout the abdomen. And we go in there and try and get it all out with surgery, and we can remove what we can see, but you can't remove microscopic cancer cells because I can't see them to remove them. And so that's why we use chemotherapy, to try and get rid of all of those microscopic cancer cells. But chemotherapy is not perfect, unfortunately. And it's the fact that it spreads so diffusely so early in the disease that we end up with high recurrence rates.
Okay, thank you for that. Okay, so someone has asked about how many times someone can take chemo and how many recurrences can actually occur.
A lot.
Okay.
Is the somewhat flippant answer there. It obviously depends very much on the person and how well they are and how well they were before getting cancer and how long they have between their cancer treatments. I have treated people who have had 10 or more lines of chemotherapy, and they do get harder. You know, the more chemotherapy you have, the harder it gets. We often have to switch chemotherapy drugs because also your bone marrow gets a little bit tired. It stops producing your hemoglobin and your red blood cells and your white blood cells as well as it otherwise would. So sometimes that can be a limiting factor. You're more likely to have allergic reactions when you get to the 10th line or the 10th time you're getting the same chemotherapy as the first time you're getting it. So there are things that limit it and cause us to have to change the treatment. But as long as you are strong enough for chemo and interested in chemo, and there's a drug that your cancer is still sensitive to, you can have chemo.
Okay, that's great.
Mhm.
So I feel like I'm just peppering you with questions, but there's so many that are coming in and we do have the time right now.
All right, go ahead.
So earlier, Dr. Roberts mentioned respiratory symptoms. Can you be a bit more specific about those symptoms?
Sure. So some people will develop, often more commonly with their initial presentation, but sometimes with recurrence. Similarly to the way that you can get ascites and the fluid in the belly, you can get fluid around the lung. It's called a pleural effusion. It's not in the lung, but it's around the lung. And that can cause shortness of breath. It can cause a dry cough. Most commonly, people will notice it initially as, well, now it's really hard to go up a flight of stairs, or I used to be able to walk for 5K and now I can only walk for 1 before I start getting really short of breath. It's most commonly a sort of slowly progressive shortness of breath that we see.
Okay, that's great. That's really helpful. So we've talked a little bit already about how to watch for recurrence, but someone has more specifically asked, I think this is a good question about the best way to watch for recurrence, because on Lynparza, many of the side effects could also be the symptoms of recurrence, like the nausea and the fatigue. So how would you advise people kind of understanding, kind of delineating the difference of what's being caused by maybe their medication and what could be a sign of a recurrence?
Excellent question. So being on Lynparza is a little bit different because you are on treatment. And when you are on treatment, we tend to monitor a little bit more carefully in terms of doing blood work and things like this, because you are on a treatment that is potentially harmful, right? There are side effects associated with any treatment that we use. So most people will still be getting routine CA-125s on Lynparza or on any maintenance therapy. Now, it's not done every single time you get blood work, but usually about once every 3 months. And so that's one way that we're keeping track on things when you're on a maintenance therapy. The other thing, when you're asking about, the symptoms being very similar, you're absolutely right, they are. And so typically what I tell people is attribute whatever you feel in the first 6 weeks of being on Lynparza to the Lynparza. Let yourself get a baseline about how you feel on this drug, and then you know how you feel. And if how you feel on this drug changes, so if the way you felt at 6 weeks, suddenly now 6 months later on the Lynparza, you feel much worse, that shouldn't really happen. Usually the way you feel on that particular drug, once you get a baseline, which typically takes about 4 to 6 weeks, that's how you're going to feel. And if that starts to feel worse, things start to get persistently, slowly, gradually worse, that's when you want to check it out.
Okay, that makes sense. So another question: how likely, how likely is recurrence? If I think that I'm kind of rewording the question, I hope I don't change the meaning. But if the original ovarian cancer is caught in early stages, how likely is the recurrence, especially if it's localized to the ovary?
So significantly less likely. So the rates of cure, which means no recurrence, increase the earlier stage you have. So again, it depends upon the type of the cancer, exactly what stage it is, but overall a stage 1 ovarian cancer, so confined to the ovary, has about an 80 to 90% cure rate, which means if you flip that, about a 10 to 20% recurrence rate. And so it depends is the short answer, but certainly having a cancer that's confined to the ovary that hasn't spread is a very good prognosis, much less chance of having a recurrence.
Okay. So you mentioned that the kind of follow-up protocol is going to vary across the country. Do you know why that variation exists? Are there standards or kind of, gold standard approaches to this kind of thing?
Tricky questions. I like it. So the gold standard follow-up is something that you will get absolutely everywhere, which is a every 3-month history and physical. That is the gold standard follow-up for an ovarian cancer, and you will get that everywhere, with the exception of the fact that you may not be getting the physical right now because of COVID. However, if you had symptoms, someone would bring you in and then you would get your physical. So that is what should be happening, and that is happening. Why things are different across provinces is a very frustrating thing to be in the healthcare system and practicing in it, is because healthcare is provincially mandated, and that means that the provinces are funded differently. What the physicians in every province and cancer care has access to is different in every province, and what is prioritized is different in every province. And that's not a very satisfactory answer. I recognize that, but unfortunately that's true. That's where we are. And it can differ within provinces as well. So I worked in Oshawa, just outside of Toronto, before moving to Winnipeg. And the way we practiced in Oshawa and how we followed up patients was different than how Princess Margaret in downtown Toronto managed patients, because they had more resources and they had more access to things than we did in a community hospital. It's not satisfying, but it is what it is. But everyone is getting the standard of care. There is no actual benefit to getting routine scans or routine CA-125s. So you're not missing anything. It's just that is why it differs.
Okay. Okay. So just kind of switching gears here for a second. Do you need like to take a breath? I'm just kind of
I'm all right.
Okay.
Ask Terry something.
All right, Terry, we're going to talk about a different type of blood test. You could either of you jump in, but one person did mention that they're actually not getting the CA-125 blood test, that they're getting something called AFP. Is that something you can speak to at all if people are wondering what AFP is?
Yes, that is for a very different type of ovarian cancer, for typically going to be for something called a yolk sac tumor or a teratoma, which are what we call germ cell tumors. So most women, particularly women who get diagnosed with ovarian cancer postmenopausally, which is most women, have what we call an epithelial ovarian cancer. It comes from the lining of the ovary, around the outside of the ovary. There are rarer forms of ovarian cancer that come from the actual meat of the ovary, what we call the stroma. They're either germ cell tumors or sex cord stromal cell tumors. They're much rarer and they have very different markers and they behave very differently. They tend to do very well. The cure rates for those cancers are very high, but we do follow them, some specific types with AFP. So that's not something that we would use for the more common types of ovarian cancer.
Okay. That's really helpful. Thank you. I hadn't heard of AFP before, so I really wanted you to answer that one. Okay, I'm trying to group a few questions together here, just around kind of the PARP inhibitors. We were talking about, I think, Lynparza before. Can we assume that you were talking about both PARP inhibitors in terms of that?
In terms of the monitoring, yes, they do have slightly different side effects, but yeah, by and large, 4 to 6 weeks, you're going to feel how you'll feel for the rest of the time. And
okay, and to kind of piggyback on that question, there's some questions about how long you can stay on it. How effective are they, and how long can you stay on them?
How long you can stay on them depends upon the drug, and it depends upon the situation in which you are taking them. So you can take a PARP inhibitor in the first line. So the first time you have treatment, we put you on it as a maintenance therapy, or if you didn't have it in the first line, you can take it with your first recurrence, so in the second line setting. The studies that we have the most data for are for Lynparza, and Lynparza was so effective that they haven't actually been able to publish the overall survival data yet because people are living for too long, which is a good thing, but it makes answering some of these questions a little bit challenging. So in terms of if you are taking a PARP inhibitor, specifically Lynparza, in the recurrent setting, so you have had your first treatment, you did not get a PARP inhibitor, you recurred, the length of time you can be on it is indefinite. You could stay on it forever. Now, there may not be that much of a point because we consider a person cured after 5 years. So whether you need to stay on it forever, we don't actually know. So we have some people who say, I'm done with taking medications, I'm going to stop at 5 years. We have some people who continue on with it. We talked about someone recently in Winnipeg who's starting year 7 and doing very well and is perfectly happy to keep going on with it. That's in the recurrent setting. In the upfront setting, it's a bit different because the trials that they ran, depending upon which drug you're looking at, were only for either 2 or 3 years. And so we only have funding for either 2 or 3 years because that was what was in the studies. So most places in Canada, if you are taking a PARP inhibitor after your very first treatment, you will be on it for either 2 or 3 years, depending upon the drug you're on.
Okay. Someone asked earlier, I'm just trying to find it, but I can't find it now, about, understanding that the, first line treatment is curative intent, and then in recurrence, it's more of a chronic disease management. But the question was, have you ever seen someone be cured from a recurrence? That's a tricky question.
I mean, I guess, yes, I have seen people have a recurrence and then have 5 years of cancer-free time.
Okay.
Based on what I know of cancer, I don't believe that that's truly a cure. In the back of my mind, I anticipate that at some point it's going to come back and they're just having a really fabulously long cancer-free time. Mm-hmm. But given that I said a cure is 5 years cancer-free, I guess technically I have to say yes. I boxed myself into a corner on that
Yeah,
one.
we trapped you a little bit there. Sorry about that. Yeah. Okay. Terry, sorry, I don't mean to kind of take over here. Terry, did you want to ask any questions that might be coming up for you as we go, or anything you'd like to share as we're kind of going through this? No, not to put you on the spot. Okay.
I'm just listening and enjoying it. No, I don't have anything new coming up.
Okay, great. Someone has asked about qualifying for medical assistance in dying for MAID. I'm not sure if this is something you could speak to, or maybe something we can follow up on later.
Oh, sure, I can answer that. So again, it is a little bit provincial, but by and large, the guidelines for MAID are federally mandated. There's a major federal court. So it is something I like to tell people, this is something that you can search out yourself. If you Google MAID in your province, they are almost always self-referrals. You do not need your oncologist to refer you for MAID. And I say that because some people are not supportive of MAID, and that's totally fine. But if it's something you're interested in, look it up yourself. And so in terms of when you qualify, you need to have a life-limiting illness, and you need to have something that says this is not acceptable to you anymore, whether that's mental suffering, physical suffering, whatever it is. You can't be feeling absolutely 100% totally fine with no concerns and say, sign me up. There has to be some sort of suffering. And they're very, very loose with the definition of what this is. So for most people who are planning to go forward with treatment of the primary diagnosis of ovarian cancer, they would not qualify for MAID at that point in time because we are treating with curative intent. Now, that's not true for everyone. Things are a little bit different. There are times where even upfront, we are not treating it with curative intent. And so certainly it's an option. But definitely with a recurrence, if it was something you wished to proceed with or investigate, I think in most provinces you would qualify at that point.
Okay. Yeah, thank you. It might feel like I'm jumping around a little bit with topics. It's just because questions are kind of coming in as we go. And I do apologize if I'm missing some, and we will circle back later. But one question I do get a lot from people is about immunotherapy and if that's an option for ovarian cancer.
Right now, no, is the short answer. There is no immunotherapy approved or covered in Canada for ovarian cancer. And realistically, the trials for immunotherapy in ovarian cancer have actually been fairly disappointing. It has not been shown to be particularly effective yet. I'm sure they'll find something eventually. We haven't found it yet. There are, I believe, still some clinical trials running or getting started, primarily in Toronto or Montreal, that are looking at immunotherapy in ovarian cancer, but they're very much trials based at this point. And clinical trials also, like everything else, took a little bit of a lull during COVID. So everything's just getting back up and running at this point. But the short answer is no, there's no immunotherapy for ovarian cancer. There doesn't appear to be anything shortly coming down the pipeline either. It hasn't proved to be particularly effective, unfortunately.
Okay. So in kind of keeping on that different types of treatment theme, can radiation be used as a treatment in recurrence?
That depends again on the type of the cancer. There are one or two types of ovarian cancer where we will use radiation for treatment. By and large, high-grade serous, the sort of standard ovarian cancer, we do not use radiation therapy as a recurrence for a recurrence treatment because radiation is a local treatment. So radiation will treat a spot of cancer. Unfortunately, ovarian cancer tends to have multiple spots that are scattered all over the place, so radiation doesn't really target it very well. However, if there's a particular spot that's causing pain, for instance, or if there's a spot in the bone, or certainly one would hope not, but if there's cancer in the brain, radiation is used for all of those types of sites. So there are circumstances in which we use it, but it tends to be very specific and not the first thing we go to.
Okay. I'm aware of the time. I'm going to try to combine a few questions together and give you just two more questions, and then we're going to let you off the hook here. So I'm going to try to bring a few together here, which is around genetic mutations and PARP inhibitors. A theme I'm kind of seeing is, does a genetic mutation, specifically the BRCA mutations coming up, is that going to change how effective a PARP inhibitor is for you? And how likely a recurrence might be? That's the other question there as well.
So the PARP inhibitors have been shown to be profoundly effective in patients who have BRCA mutations. The BRCA mutations, those patients, whether you have what we call a germline BRCA mutation, so that's a mutation that is inherited and you carry in your bloodstream, or a somatic BRCA mutation, which is a you didn't inherit the mutation, you won't pass it on, but your tumor specifically has the mutation. Those patients do very, very, very well with PARP inhibitors. They are the patients for whom the overall survival has been increased by years and years and years in the trials, and we haven't figured out by how much yet, because they're still living well and doing so well. That's not to say that the PARP inhibitors are not helpful for patients who do not have a BRCA mutation. They are still helpful, but the magnitude of benefit is not nearly as significant as those who have a BRCA mutation. So in terms of recurrence risk, if you have a BRCA mutation and you are on a PARP inhibitor, yes, your recurrence risk is definitely much lower than it would be if you had a BRCA mutation and were not on a PARP inhibitor, or if you didn't have a BRCA mutation at all.
Okay, that makes a lot of sense. And I'm going to finish off with one question here. And I just want everyone whose questions we didn't get to. I see them, I'm reading them. I don't want you to feel like you're being ignored. And we are going to try to follow up and get as many of these answered as possible. And Dr. Roberts, not to paint you into a corner here, but your thing about 5 years with no recurrence, you would consider it a cured patient. Do all gynae oncologists feel that way?
I can't speak for all gynae oncologists, but I would expect so. Sort of this standard definition of a cure of cancer in most cancers, but certainly most gynecologic cancers, is 5 years cancer-free. Every trial looks at 5-year overall survival, which like cancer-free overall survival, and that's broadly speaking the definition we use. Again, there are depending upon your cancer subtype a few exceptions, but by and large, if you have your primary treatment and have had 5 years of follow-up with cancer care, you are going to be discharged at that point. And that's, again, minus a few very small exceptions, that's pretty standard. So that's what we're aiming for.
Okay, that's great. Thank you so much. I'd like to thank both of you, Dr. Roberts and Terry, for sharing your obvious wisdom, your tips and tricks, your advice, and all of your knowledge with us this evening. We're so grateful. And I'll let you off the hook now. You guys can both take a breath. And I just want to go over one more item before we move on to our next session. So the Every Woman Studied identified many gaps in our healthcare system and revealed more about the emotional experiences of people affected by ovarian cancer. So in response to those findings, we're in the process of developing a set of tools that are going to enable those affected by ovarian cancer to make informed decisions about their care. All the tools are being developed in collaboration with a diverse group of experts, including patients. And we're using design frameworks to engage as many different types of people as possible. So including people with different levels of education and language barriers and neurodivergence and learning disabilities. We know that many of these issues that the tools are going to aim to address are really big healthcare system issues. So at Ovarian Cancer Canada, we are working to better understand these larger system level issues so that we can effectively advocate for change. But while we do so, we're hoping that these tools will empower patients and their loved ones to advocate for their own care. So as it relates to this session that we've just had, one of the tools in development is an understanding recurrence monitoring tool. So we know from the results, again, from the Every Woman study, that fear of recurrence is the greatest emotional challenge among people affected by ovarian cancer. So this tool will hopefully help people to better understand their follow-up care plans, how they're going to be monitored for recurrence, and will support these effective conversations with their healthcare team about recurrence monitoring. So if you have any questions about that tool, or if you want to provide your input into the development of that tool, please get in touch with me. I'll put my email address in the chat, and I'd be happy to talk with you about that further. And I'll just tell you now, my email address is aross@ovariancanada.org. So again, a huge thank you to Dr. Roberts and to Terry. And Steph, are we good to move on then to our next session? Before I throw it right into the next session, I just want to make sure we're all ready to go.
Yes, you bet. We're ready to go.
Okay, great. Thank you
both for that excellent session.
Yes.
Thank you, Dr.
So many
Roberts.
questions.
Thank you.
So we can tell.
Thank you for having me.
How people were so interested with how busy the chat is. So we have another great topic coming up next. It's titled Mind the Gap with Shaliza Sajwani. So Shaliza is an ovarian cancer survivor and an oncology pharmacist working at the Ottawa Hospital. She has experience in both outpatient and inpatient oncology. And along with working in oncology, she's currently subspecializing in palliative care and has a deep passion for focusing medication management on patient-centered goals, priorities, and values. Understanding information that's shared during appointments helps to build trust between patients and their healthcare providers. So Shalisa will share with us tonight some tips that will help you comprehend the clinical information being shared with you so you can feel confident and supported along your journey. So enough from me, over to you, Shalisa.
Thank you so much. It's lovely to meet all of you. I will just share my screen. I have some very informal slides, but I'm hoping that we will have some great time for questions as well. And I'm really looking forward to interacting with all of you. So I will share my screen now. Okay. So I did have some problems with slides lagging behind with a separate presentation today. So if the staff at Ovarian Cancer Canada, if you can let me know if there's any issues with the slides kind of being parallel with my voice. And I'll make sure that I slow down so that the slides basically catch up. So the topic of my presentation today is Mind the Gap. And for those of you who have heard of the term Mind the Gap, if you've ever been to England, when you're going on a tube, the subway system, there's something in the background saying Mind the Gap between the train and the platform. But here we're actually thinking about Mind the Gap between the perspectives and the thinking of patients and their healthcare professionals. And the reason why I'm presenting today is to try to bridge that gap. I have also done presentations for healthcare professionals as well, based on my time as a patient. I still go for follow-up appointments, so I'm not at that 5-year mark. But as an oncology pharmacist, I basically go for my follow-ups, and I also do presentations to my colleagues and to others, basically about how to think about values and priorities of patients when interacting with patients on a day-to-day basis. But today we're here for you. So just a little bit about me. I spent 5 years. I have 5 years of experience as an outpatient oncology pharmacist and 2 years of experience as an inpatient oncology pharmacist. When I was a month shy of my 31st birthday, so I was 30 years old, I was suddenly diagnosed with ovarian cancer. And I had a sudden ovarian torsion, which revealed a 12-centimeter mass in my abdomen. Staging wasn't clear right away, but later on I found out that I had a 1C clear cell, part clear cell, part endometrioid ovarian cancer. And I was treated by my colleagues, and I went through the process like many of you. I went through carboplatin and paclitaxel, like a lot of you may have experienced. And in 2019, after a full radical hysterectomy, I went into remission. And I know for those of you who are in remission, I know I understand what happens in the time after remission with regards to managing and trying to figure out your new path. I have been now 3 years in remission, but I can safely say that ovarian cancer has completely changed my life. About 2 years ago, I returned as an oncology pharmacist and I switched to inpatient oncology. So I see cancer patients on a regular basis. And I also have subspecialized in palliative care. So I just wanted to let you know my background, and this is a photo of me once I've just finished all of my treatment, as well as this was basically during my last surgery, so my first day of remission. So I wanted to basically thank a few individuals, an individual from Cancer Care Manitoba, a psychologist, and individuals from Young Adult Cancer Canada who helped me with regards to getting some information. I'm an oncology pharmacist, but some of this information comes from the psychology lens as well, and social worker lens. So I thought I'd ask you today to reflect on what are your priorities as to what is important to you while you're going through your treatment. Do you feel that your values and your priorities are being respected while you go through treatment, and or even if you're not in treatment? And do you feel supported in that path? Do you know how to communicate your values? So are you a participant in the process? So when you are discussing with your physician, is it more of a kind of instruction that the physician basically, or the healthcare provider tells you that you have to do X, Y, Z? Or is it kind of like a dialogue, a back and forth kind of dialogue when you're discussing with your provider? The same can be asked of supporters as well, people who are supporting individuals who are going through ovarian cancer, who are family members or friends. Are you noticing that your family members' values, for example, are being respected, and are their values being respected? So why is this happening? So I'll backtrack a bit by saying that sometimes there can be, there are studies that show some form of systemic bias that exists within the healthcare system. So for example, if someone is very young, then there could be that thinking that, oh, this person is very young, they don't perhaps know their values or know their priorities. Or if they're a lot older, there may be some thinking that this person can't manage their, by maybe there's some kind of assumption about absent-mindedness or infantilizing that can sometimes happen with ageism. The patient-provider relationship is also an interesting one. So years and years ago, I would say years and years, 20 years ago, the idea was that the patient-provider relationship should have been more of a paternalistic type relationship, where the physician or the healthcare provider is the one that basically, is the one that has all the power, and the patient is the dependent. So therefore, the patient follows what the provider has to say. And there wasn't as much patient involvement in decision-making. And now in med schools, they're teaching a more horizontal type relationship. So you are able to, in theory, the way that it's taught, you're supposed to be able to express your values, your priorities, what you think while you are interacting with your provider, so that they can understand what your values and priorities are. And this is particularly relevant in palliative care, although not exclusive to palliative care. So things are changing, but they're not, change doesn't happen overnight. So it's moving in that direction, but we need educational presentations such as these to help move it in the right direction. There can be other factors too. So there's data about systemic racism, for example, that also exists. So if you think about the data that has come out about how patients have felt if they are Indigenous and they're maneuvering a healthcare system that is not completely built around their needs as well, and their cultures, there can be some other factors as well that can influence both systemic bias as well as how the healthcare system is structured. Provider and patient trust is a big one. There was one study that showed that it takes an average of 29 seconds for somebody to mention their priorities. However, it took an average of 11 seconds before they were interrupted by a healthcare provider. So maybe you've heard the words, it's all in your head, maybe you're just anxious. So these are things that can affect issues with regards to systemic bias as well. Particularly, I mean, ovarian cancer is a generally female's illness. So this can also intersect with some unconscious sexism as well. So the good cancer, not really a phrase that's mentioned about ovarian cancer, but certainly if you have if you are one of the minority that is diagnosed early, you'll be told that, oh, you know, oh, don't worry, you're very lucky, or you have a good cancer or something like that, when really no cancer is really good. So everything is all kind of comparative. I was told a lot that I was very lucky for having a relatively early stage cancer. But of course, most of my colleagues who are 30, 31 or so are relative, my age, who are relatively healthy. So all of this, the good cancer is kind of, it's a tough phrase to use. The spiel while counseling. So you may be taught about your side effects, and you may be told that, oh, treatment can cause X, Y, Z side effect, but is it really a dialogue versus is it a back and forth conversation? And again, are there good or bad cancers? Why are you struggling if it's a good cancer or if it's an early stage? This can be particularly difficult when you add survivor's guilt there, because you may be having friends with individuals who have either passed away or are diagnosed more later or have experienced a recurrence. I know I have many friends who have advanced disease. It's very important to realize that each person has their own path, so we should not be using that kind of terminology. Some other things, so sometimes the diagnosis can be very sudden, and you're given so much information at the same time. Information overload, and you also have emotional overload from what is being told to you, and what certain things you can do to kind of help manage that is first having someone with you. Sometimes this can be challenging with COVID, but even having someone on the phone sometimes helps. I used to keep a notebook with me because people assume that because I was a professional, I would never get overloaded. But you know, when your mortality is kind of brought to your eyes at a very unexpected time, and there's so many things in the air, you will get overloaded. And so I found it was helpful to plan my questions in advance, to write my questions in a notebook, one spot for questions, one spot for answers, and then just basically go through my questions at the appointment. And that I found particularly helpful. There's a lot that's also being that's taking place in med school and in other professional schools about being seen as a person versus the patient. So for example, empathy versus sympathy. It's important when you realize that you have someone who's empathizing with you, it can make a world of a difference with regards to the conversation with healthcare professionals. And there's a lot of dialogue that happens with regards to, there's a lot of conversations that can happen with regards to empathy versus sympathy. And then of course, cancer recurrence. I know there's a lot of information that was talked about cancer recurrence. One thing to keep in mind with regards to communicating with your healthcare provider, if you, for example, you're experiencing symptoms that you feel that are worrisome for recurrence, and your provider asks, you know, are you sure you're not just anxious, because cancer can increase your risk of depression and anxiety. One way to respond back would be, I know how normal anxiety feels like, or how my normal depressive symptoms feel like if you have gone through depressive symptoms, but this feels different. And that's a way to be able to communicate, to say that, you know, this is not something that is quote unquote in my head. So similar to questions about nausea or pain, you can answer questions in these types of ways. But one thing to realize is that these are system issues. These are not individual healthcare provider issues. These are not patient-related issues. This is not a problem that is because of you. These are systemic issues that take some time to resolve, but get better with education. So this is a slide I often keep with when I'm talking to healthcare providers, just moving towards from empathy to compassion. But one thing I wanted to talk about with you is to think about, first, of course, we want to think about whether the healthcare provider has empathy and compassion for yourself, moving from pity and sympathy to empathy and compassion, seeing you as a person. But also, how do you see yourself? So when you're able to have empathy for yourself, you can and have compassion for yourself. You're a lot more understanding, and you kind of give yourself a break a little bit more. It's the difference between, for example, saying that, oh, I have something that I'd like to improve on, versus I am bad and I'm worthless and I am just a patient now and nothing else is, nothing can be done, in the sense that my whole personality has left me. This is something that we often go through during diagnosis, in the sense that you can feel like your personality is leaving, but you are still you. You just also have cancer, and that will affect aspects of your personality, but you are still you with cancer. So it's a good idea to think about how can you incorporate self-compassion with that, by figuring out how to incorporate adjustments to your day-to-day lifestyle, while also seeking out psychosocial supports. You to your healthcare provider. So that's not one that's thought of often, but of course, the healthcare professionals were also kind of really burnt out by COVID, and are very, very short-staffed right now. So that is also an area that we can think about too. Of course, it's a very sensitive area, because a lot of us have sometimes experienced not enough on the vice versa. So it's sometimes hard to think about yourself to healthcare professionals, but it may be good to start with, in your mind, start with a healthcare provider who has been very good to you and who has been more empathetic, and then start there, and then start thinking about the other healthcare professionals after that, because that will be a little bit easier on yourself as well. So what motivates you? One quote I got from a Young Adult Cancer Canada individual was that they are concerned about whether I live or not, but they're not concerned about whether the cancer destroys who I am. So it's a good idea to understand what actually motivates you. What are your priorities? What are your values? So for example, a lot of the young adults that I talked to, a lot of their priorities were their exams, their relationship, their ships, their work, sometimes fertility. Sometimes if it may be that neuropathy is, for example, a side effect that you cannot, like it would be very, very disruptive to your life because of certain activities that you feel fulfill you as a person. Perhaps it's time with your grandchildren or your children that make you feel fulfilled. But it's important to have an idea and explore what motivates you and what are your priorities. And if you can write these down, you can actually also be able to communicate these with your provider as well. You can also then deal with team assumptions. So for example, a team may assume that either you are willing to go through any treatment despite any adverse effect consequence, or they may assume the opposite, that you should or you may want to stop therapy at a particular treatment at a point in time. But really, they can give you the advice, they can give you the data, but really it is your life, and these are your values and your priorities. So you can basically start writing down what are your values, what are your goals, and share those with your family, and then also share those with your healthcare provider as well, to prevent them from making assumptions. which they shouldn't, but we can give them a little bit of a break because sometimes there are knowledge gaps in those areas. How do you communicate your values? So one thing to think about, so we often talk about goals of care in the healthcare professional world as to what are the goals of care. Is it full treatment? Is it comfort care? But instead, in the patient world, we can think about what are our goals of living? What does successful treatment look like for you? And what does a successful life in your circumstance look for you? So for example, if you have a dire prognosis, in those 4 or 5 months, or in those 6 months, or in that year, what do you want to prioritize within that period, that period of time? So these are, I have a couple of examples that are non-ovarian cancer specific, but you have, for example, a 20-year-old woman. This could easily be a stage 1C ovarian cancer or 1B ovarian cancer. And her priorities are to finish her art degree and keep painting. Neuropathy might be something that she's very worried about. Case 2, another person with metastatic ovarian cancer, I'll just say, and she wants to spend time with her 5-year-old child. And that is the thing that gives her the most fulfillment. So that might influence the amount of lines of therapy that she pursues. So one can basically then talk to the staff to say, this is what is important to me. These are my values, and this is what's important to me. And also have that conversation with your friends and family as well. You can move around to different providers if you feel that one is not necessarily understanding your priorities or your values. And sometimes it's not even about understanding. It's just about how you fit well. So for example, while I was going through treatment, I was looking for someone as someone who had an oncology pharmacist background who would feel comfortable discussing clinical trials with me. And some providers do not feel comfortable discussing clinical trials with patients, which is totally understandable. But that's what I was looking for during treatment. After treatment, I was looking for someone who had more experience in survivorship, for example, because a lot of providers have less experience with regards to survivorship specifically. So different providers have different strengths. You can also do the same with regards to a pharmacist, a social worker, a nurse. If you have a particular nurse that you would really like, you can express that to your clerk. You can mention that to a booking clerk with regards to a physician. However, once you find one that you think is really works well for you, trying to stick with that one is helpful because that person then has a better idea of your history. Of course, there are notes in the system that should provide each professional with the relevant information, but sometimes it's helpful for provider-patient relationships if you can stick with one. In some centers, unfortunately, they have a rotating system, so it's difficult to kind of stick with one. And in that case, I would recommend having all of your information kind of ready at hand if you can. If not, the notes should be in the system. Choosing a pharmacy, I would try to stick with one community pharmacy as well, because the community pharmacist also kind of does their own interactions check, and you can build a relationship with the community pharmacist as well. Don't be afraid of asking for a second opinion from anyone on first diagnosis. People are human. You can ask for second opinions. It's your life, and don't let people tell you that no, this is the box and you must follow XYZ. So feel free to ask for a second opinion if you feel like that also will help you and give you peace of mind. Family doctors are underestimated. People think, so the oncologists are focused on the cancer. Family doctors are thinking about you as a whole with regards to other comorbidity, other illnesses that you may have, treating the side effects, for example, of your illness. And it's important to keep your family doctor updated. It becomes even more important after, if you're somebody who you have finished 6 cycles of chemo, for example, and now you're on, like you're being followed up every 3 months, for example, regardless of your staging. Your family doctor can often be a really big advocate for you as well once you're experiencing symptoms at different points. So I had an excellent family doctor that I was very lucky to have, who really helped me with chronic care and survivorship. A lot of cancer centers also have a patient support line who you can, which you can call for to mention that you have XYZ symptoms, and they're staffed by nurses, and they will basically triage you to the right place. You can ask your nurse and physician as well. Some provinces have their own separate private kind of support lines as well. So there are also external programs, for example, Inspire Health in BC sees patients as well, including, and they have doctors and dietitians, nurses as well. I want to underline the importance of psychosocial. I think it's so underestimated, and a lot of the time you won't get a referral to psychosocial unless a provider can visibly tell that you are quite distressed. With a lot of us, we go into our appointments and we really look like we know what we're doing. And then we come home and it just, the magnitude of the diagnosis just hits us. And having a psychosocial program is really helpful. So if you tell your provider, you can ask them, your oncologist, is there a psychosocial program that exists? And does it provide therapy, or a psychologist or a psychiatrist? That individual can, you can get a referral for a psychosocial program, and then they can see you every few weeks or however, I think every 2 weeks to every 4 weeks, and sometimes a little bit further apart. It's important if you're newly diagnosed to get that referral in early, because sometimes there can be a delay. So the big takeaway from a delay in terms of wait lists. So the big takeaway with regards to psychosocial is that it's not always brought up with patients, and it's a good idea to inquire about it, because you can potentially, depending on your center, get free therapy. Which is pretty massive when you think about all the different things that cancer can throw your way. What about mental ability? So trauma can affect individuals, it can affect families, it can affect cultures and communities. If you think about the intergenerational trauma with the Indigenous residential school system, for example. It can also affect service providers. So you can think about the trauma that they have experienced, seeing patients, for example, that they've gotten close to pass away or go through a lot of suffering. But the important thing to think about here is that cancer is also, going through cancer is a traumatic experience. Whether it's an early stage or a late stage cancer, it's a traumatic experience. And it's tough for both the survivors and individuals in the Teal sisters and the supporters as well. So what does that mean? Trauma can in fact impact our nervous system. It can impact our ability to regulate our emotions, so our fight, flight, or freeze response. It can affect, again, our emotional regulation, our ability to stabilize. It can then have an impact on our physical and mental health and our relationships, even our connection to spirituality and community. And therefore, it has a lot of different impacts on different areas of our life. So physical health, mental health, relationships, community, etc. So one thing, the reason why I'm bringing this up is because instead of having the question, what's wrong with me? or as to why am I behaving in this way, or if you're receiving the questions, what's wrong with you, etc. Maybe you can also think of yourself as someone who has gone through a traumatic experience, and it takes much, much longer to heal from that trauma than it does to just kind of get a few cycles of chemo. If you're somebody who is on chemo for life, then that is also something where you can also very much understand that this is also a very, very traumatic experience as well. So understanding that and giving yourself self-compassion is very important here. Trauma, mental health in general is very stigmatized. So you can, again, think of the phrase, what's wrong with me? And you can change it to what happened to me? And the what happened to me question will help you kind of deconstruct what happened, why is it traumatic, and what can you do now about it? It will also give you some more awareness about your own mental health needs. No matter how mental health is a spectrum. So no matter how good your mental health is at any one point in time, it can get better. And again, it's a good idea to understand how to communicate your needs as well. So I've provided a quote here that some people experience nausea because of anxiety, for example. So they experience anxiety and then they get nauseous. But let's say you are experiencing nausea and you're worried that it's related to a recurrence. And how do you communicate that? You can say that, look, a lot of my nausea is related to anxiety, but I'm not feeling anxious right now. And my nausea is higher than normal. So that's a way to be able to communicate that, look, this is a different kind of symptom. And that will help your provider basically identify that. I'm going to preface this by saying that, of course, that education has to happen on both sides. The providers also have to get that education about how to identify these things as well. But we're doing education we're doing patient education today. A big trauma response is a fight or flee response. So sometimes when you're in an appointment, you might freeze and you may completely not understand what the provider is telling you. So therefore, having a notebook with questions and a spot for answers, again, is useful, and then having somebody with you. Also, one of the questions could be, if I have questions later, who can I contact? And that way you will feel peace of mind that when the physician gets up and leaves, or when the pharmacist gets up and leaves, you'll know who you can contact if you have more questions. Speaking of questions, we're now at the end of the presentation. So I just wanted to say it's great meeting all of you. I hope I'm running kind of on time, and I would entertain any questions at this time.
All right, thank you so much. This was a really fabulous presentation. So lots of questions are coming into the chat, so I'm just going to try to group a few together and see what we get through here. So you did mention at one point that sometimes you've noticed oncologists are not comfortable discussing clinical trials. So someone's just wondering if you could expand on that a little bit.
Yeah. So I think it really depends on the oncologist. I won't paint everyone in a same brush. There are some oncologists who feel very comfortable discussing the results of clinical trials. So to give you an idea, I was very, I wanted to talk about, survival curves and like data on, patient populations and the whether a small study could be taken seriously or not. So I was looking at myself from the perspective of a provider as well. Mm-hmm. So I don't know how many providers would feel comfortable talking to another person who is a patient, but is also, trying to analyze herself as a provider.
Sure.
There are also some who, a very small minority who may not feel comfortable talking because they're used to a more, top-down type of relationship. Mm-hmm. I actually feel more optimistic. I feel that most are not in like completely on that extreme right now. But again, systemic changes do take time to kind of roll out.
Absolutely. Okay, so the first question that came in was, how do you deal with paternalistic attitudes when you don't want to anger your doctor? It's a big question.
Oh my God. Okay.
I feel like I'm really putting the speakers on the spot today.
Yeah, no, it's a really good question. It's a tough question. And if you have an option to find another provider, if you're getting into that level of paternalistic attitudes, you have your right to. So don't be kind of put in a corner if you can that way. If you do have access to other providers. If you don't, the best thing that I can tell you is I'm sorry that this is happening to you. First, this is a result of a system that still has not moved forward in certain situations. I would really reserve that time half an hour prior to that appointment or an hour prior to that appointment to think about the questions that you have and think about how you're going to communicate your values and your priorities. Yeah. And really also think about how you're going to calm down your fight and freeze response, which is a very natural response to have as well, because the paternalistic attitude can also be mentally tough for mental health.
Sure.
So taking that time before is helpful. Also having somebody with you who will have your back. That can be very helpful. Even if it's like a COVID outbreak, you can also have somebody over the phone who really has your back. A family doctor, getting a referral from a family doctor is particularly helpful as well, or another physician who that this physician is going to take seriously. Yeah. That can sometimes be helpful. But I do feel sad mentioning these responses, because really it shouldn't be your responsibility to do that. But this is just an unfortunate situation where these are just some tips to maneuver around the system.
Yeah, no, it's very good advice. I'm going to kind of bring two questions together with this one. So someone's written, how exactly would someone change their oncologist if they like one more than the other? We don't choose one at the outset, so it never occurred to me that we could switch. Would there be a conversation with one's GP? And then the other question under that is, how do I go about asking for a second opinion? I'm worried it will affect my standard of care. So I think we're kind of looking at the same question, same themes there.
Yeah, so sometimes there is a patient engagement or like some patient feedback or some kind of phone number that you can contact about that. Sometimes the patient support line can be also helpful, because the nurses do not have that kind of bias, and you can kind of say that, I would prefer switching to a different oncologist. How do I move around that? Mm-hmm. Those two are good options. Mm-hmm. Second opinions are a little bit more challenging. So you can ask the patient support line as to whether another physician is available for a second opinion. Somebody has written in the chat about Cancer Connect Canada, which might be helpful. Sometimes when people are deciding whether to move from one center to another center in the same city, or that is in a neighboring city, they can sometimes get a referral, and another physician can kind of review the documentation that way as well. I know that's not really that helpful, but it is a tough one with regards to second opinions. But I would start with your patient support line, as well as any kind of external agency like Cancer Connect, it would also be helpful too.
Okay, and what about the conversation with someone's GP? Do you think that is something
Yeah.
that people could try?
The one thing I forgot to mention is that not all oncologists, so gyne-oncs are a specific type of oncologist.
Mhm.
There are other types of oncologists that treat breast cancer, other types that treat like GI cancers, etc. So not every oncologist is the same. So really you're looking for a gyne-onc. A family doctor can sometimes be useful. Particularly when I was looking for a family doctor, I was also looking for someone who had experience treating cancer patients or had worked in the hospital setting with cancer patients at some point. Sometimes that is a very, very difficult thing to find though. Family doctors can sometimes be helpful. You can bring this up with your family doctor. There's no harm if they have experience working in that kind of. So some family doctors have done like rotations in the hospital, or they have basically done some kind of relief shifts in the hospital, and they may have some contacts, and that is particularly helpful. But usually it would be within your cancer center.
Sure. Okay, thank you. We're out of time. I know there's some more questions, so again, apologies we couldn't get to all of them, but I want to thank you so much, Shaliza, for helping us bridge that gap between the patient and the healthcare provider. You've given some awesome tips and some really great insights. So thank you for being with us, and thanks for everyone for all the great questions. And that wraps up our first half of this evening. So our break's going to be a little bit shorter than anticipated. So about 8 minutes if everyone wants to come back at 7:50 Eastern time. And I encourage you to get up and take a little break and stretch your legs, and see you back here in just a few minutes.
Everyone, we are going to jump right into the second half of our evening. In our first session, after the break here, we are going to hear from two remarkable women about caregiving and care getting, and just how important support is in your cancer journey. Paula Holmes Rodman is a cultural anthropologist who worked with Pueblo and Navajo women in New Mexico. She is also a caregiver for her big sister, Lindsay, who is living with ovarian cancer as a person with autism. Paula lives on Vancouver Island, where her favorite acts of self-care are hiking and storytelling. Victoria Schutze is a recent transplant to Winnipeg from British Columbia, who is currently experiencing an ovarian cancer recurrence after her initial diagnosis of stage 3C high-grade serous in July 2021. She lives with her very supportive husband, 2 teenage daughters, dog, and 2 cats. Now, Paula, I'm going to turn it over to you.
Thanks so much, Stephanie. Everyone can hear me okay? Great.
Sounds great.
Good, thanks. So my name is Paula, and my Teal sister is my real sister, Lindsay. So Lindsay was diagnosed in October 2019 with stage 4 ovarian cancer. And after chemo, surgery, more chemo, and now going into her 3rd year of Lynparza, she's feeling really optimistic. But Lindsay's also on the autism spectrum. And so I refer to myself these days as sort of caregiver in chief. So let me explain. Just before Lindsay was diagnosed, we lost our mom. And I migrated directly from being mom's primary caregiver to being my sister's. And then just a year ago, my husband was diagnosed with advanced prostate cancer. And so I feel like my ground hasn't stopped moving in terms of how I support all these people and love all these people. But some of the more unique challenges I think I face with supporting Lindsay are distance. We live in different provinces, and I noticed that in one of the chats, one of the other women was wanting to support her sister who was in a different province, and also navigating her autism. So there are pragmatic challenges for being a caregiver from a distance, and these are multiplied by the pandemic and an over-reliance on technology. So Lindsay's first appointments and her surgery took place before the pandemic, and I traveled 3 times in 3 months from Vancouver Island to Calgary, arriving home just a week before the world shut down in March 2020, just getting in there right after her surgery. So we actually call ourselves lucky that I was able to be with her for her surgery for that. And since then, we visit as much as possible. We text every day, and we have this wonderful long 2-hour talk every Sunday morning. And I attend all her cancer center appointments. And I put attend in quotation marks because it's by phone or video. Some of these are a little bit sketchy, depending on what cancer center. She goes to Tom Baker, and that is currently located in the basement. The cell service sucks. So yeah, that could be a little bit better supported. Let's put it that way. But before this, I prepare all the questions for her with back and forth. I write up the questions. She prints them out. She's a copy for her. I have a copy. I'm on the phone. Doctors have a copy. I take notes. I write them all up. I send them back to her. It's a thing. So, but it's a balance, I think, between acting these roles as sort of project manager, what I call Lindsay translator, and information wrangler, and still be your sister. And that's a tough one. But today I'd like to look at a couple of the other roles I have as caregiver that these may resonate with, or maybe hopefully encourage other caregivers out there, and look more closely at how Lindsay and I have navigated this journey. I know the word journey sucks, like I know, but based on the realities of her autism and our distance as well. So roles of the caregiver, I'm looking at 3. First one is caregiver as storyteller. And I'm thinking here of stories of the past, the present, and the future. Caregiver as storyteller of the past. Keep in circulation all those stories that sustain you, sustain your Teal sister. That keep in circulation the pre-cancer stories, all the family memories, the funny ones, the sad ones. Lindsay and I do a lot of, remember when mom said that, or grandma did that. Cancer and caregiving don't happen in a vacuum, obviously. And reminding your loved one and yourself of this continuity and context is in fact a great act of care, not only for her, but also for yourself, as it turns out. And the second is storyteller of the present. So find new ways to listen to, and where appropriate, share her cancer story. Allow her to tell her story in the manner and pace she wishes. And I would also say if she wishes here. So I actually interviewed Lindsay over Zoom, and I got 36 single space pages, which I did not expect. And it was wonderful. We laughed, we cried. It was great. It was just great. And I wanted to interview her as a woman on the autism spectrum. So I talked to her about her diagnosis as a woman who was diagnosed as an adult. And I tried to the best of my ability to recreate that 2-hour Sunday phone call, that chit chat. You know, we were eating, drinking in our pajamas. It was great. And then I transcribed it word for word, gesture for gesture, emotion for emotion, as a testament, not only to her journey, but also to our relationship. And we have favorite parts of this now story, the present story, including just after her surgery, Lindsay was kind of loopy on drugs, and she woke up and she said, I'm just lying down on the road for a bit, but I'll get up in a minute. And that makes us laugh every time. And I encourage you to find the things that make you laugh in the now story, in the present story. So this now story turned out to be an incredible gift, not only I think for Lindsay, because I was able to gift it to her, but now I have it as well. And I've learned more about her in the last, I've learned more about her in the last 3 years than I've known in the 50 plus years she's been as my sister, which makes me both dance with joy and weep as well. But it's kind of amazing. So storyteller of the future. This could be sharing these hopeful stories about what you hope will happen after cancer, if you think there is an after cancer, or what you hope will happen next. Or it could be as a caregiver preparing in your own mind for legacy tales and for what I call keeping the story going. So Lindsay and I have a new niece. We have a younger sister, and she was born last year on Lindsay's birthday. And I really cried that day, I have to say. And on sad days, I do think about what I will tell that little niece about her brave Auntie Lindsay, if Lindsay's not around here to do it herself. So storytelling then can be an act of caregiving, but also care getting. So don't leave the lives of your Teal sisters unstoried. Cancer fractures and breaks the life into before and after and next. Stories knit the bones back together and have a profound healing effect for both of you, I think. Second role, caregiver as a rodeo clown. Okay, look out, here come a whole bunch of cowboy metaphors. Forgive us, we were raised in Calgary. Okay. A rodeo clown, apparently, maybe everybody knows that this is the person dressed in funny things that distracts the bull when the rider gets bucked off, okay? So the caregiver's job as rodeo clown is distraction. You wave your arms and say, hey, over here, while your cowgirl, your Teal sister, has a moment to dust herself off and find her feet again. So I distract Lindsay, and in fact, we distract each other with very important things. Cat videos, in-depth discussions about sports bras and lipsticks, pet antics, travel plans, and thrift store fashion finds. And because of the distance, this is primarily done with phone and text. But Lindsay gets sort of bucked off, not just by elements of her cancer, but also elements of her autism. And this comes in the form of information and sensory overload for her primarily. So being her rodeo clown means being attuned to those physical and verbal cues that she's had enough, that she's done. And then I need to realize at that moment that the greatest act of care that I can do is in fact distraction. It's a cat video, actually. That's the greatest act of love sometimes you can do. And then finally, caregiver as hitching post. I warned you about the cowboy metaphors. So the caregiver's role as a hitching post is to be a quiet, unmoving tether. Be grounding, be sturdy, be there. Find strength in simply bearing witness, in holding her hand, even if it's just by phone. So once Lindsay was in the ER for bloating and pain, I'm freaking out in my head, there's recurrence happening. And I can't say this. I'm trying to walk with her how she's doing. She's not doing well. She is having sensory overload, all the bells and all the busyness of all the nurses. It's too much for her. Well, all my words failed and all my great ideas failed. And maybe yours will as a caregiver. They will probably at some point. I just simply said, I'm here. I'm here. That's all I could do. So learning to sit with that silence and feeling of powerlessness is in fact an essential act of caregiving, I would say. And not only for your Teal sister, but also for yourself. So as a hitching post, what I do is I counter the constant recalibration and recalculation required in a fast-moving cancer journey. And these changes are especially difficult for someone like Lindsay with processing difficulties, who finds safety and a sense of wellness in routine and predictability. But by being still, quiet, present, there, I not only tether her as an act of care, but in so doing provide grounding for myself and come to the important realization that she's holding my hand too. So Victoria, what have been some of the most important kinds of support that you received and some of the least helpful? I know you've talked to a lot of other Teal sisters as well.
Hi, Paula. Wow, that was really amazing. How do we follow that up, guys?
Oh, you've got surveys. So.
Thank you so much, Stephanie, for the great introduction, and Paula for such a great stage to share with here. So as most of you know, I'm Victoria, diagnosed with stage 3C high-grade serous last year in July. It's been crazy. I was super devastated, and not just for my husband and my kids, but for myself, for every minute of life unlived, for all of the fear that I have that I'll never do those things that I wanted to do. So I had 9 rounds of chemo, full hysterectomy, all the extras except a tummy tuck, and I'm still here. I finished chemo in May. My recurrence was found in July. So I'm platinum resistant, I'm no longer curative, and I'm just living every day up to as much as I can do. Throughout this journey, though, support in all its forms has played this huge role in my well-being, both physically and mentally, from start to finish and continuing. Support is paramount to recovery and continuance of our good health. And I'm just so proud and so pleased and so honored to speak with you all today on the various ways in which we can support ourselves as cancer warriors, and our caregivers too, because they need it as well as we do. So just to start off with all of this, I wanted to define the basic different types of support. And for a lot of you, this won't be news at all, but just so that we can kind of go along and understand, the quotes that come later. So the first is emotional support. And honestly, for the cancer warrior, calming fears, showing empathy and compassion, encouraging people on difficult days, reminding me how far I've come. My husband often says, like, when I'm reminded I couldn't even make a whole dinner for my family once, and now I can batch cook a week's worth in an afternoon. Sometimes I'd forget something upstairs and I just wouldn't have the energy for a single flight of stairs. And now if I forget something at the bottom of the stairs, I can go back up. So reminding us that, I'm coming and healing every day, helping us to feel still here by sharing your experiences, just like Lindsay said. So the good and the bad, and providing a distraction from what we're going through with a funny story, with a picture, everything that Paula suggested too is really great. But also for the caregiver, we want to hold space for them to express their feelings. They're going through a deep grief and all of the accompanying emotions to the prospect of losing you, to losing us. They need comfort as well as we do. So if we can't provide that comfort, maybe we can find an outlet for them. There's often caregiver group therapies. Cancer centers offer those free of charge as well. There's also practical and tangible support. Because cancer has such an impact on the body's, physical ability to perform all tasks necessary to life, making meals, house cleaning, just being active. And often it affects our ability to work as well. So while many employers offer long-term disability, the government has some benefits. Honestly, as most of us will probably agree, none of it is ever really enough. So offering to help with practical and tangible support, such as making meals, covering a bill or an expense, that can be really useful, especially when additional expenses have come up, like hospital parking, prescriptions, comfort items to help with chemo and surgery. It can be really hard. So providing gift cards for meal companies, house cleaning, drugstores, super welcome, often appreciated. Offering to help with a bill or a comfort item. Often these things can be really hard for people to ask for. And even for folks in the audience that, times can be tough. If you're not financially able to provide those things, just call them up and offer to go and help with laundry or do dishes. Helping in some practical way can be really, really useful. Dropping off a meal, offering to drive to chemo. This helps both the cancer warrior and their caregivers, because their caregivers have a little reducement in their burden as well. There's also physical support. So as a lot of us know, we can't do those physical tasks. It robs us of who we were body-wise, leaves us feeling powerless. There were days I couldn't even make it to the bathroom by myself, and I'm just really grateful to my husband for carrying me there, honestly. So for the cancer warrior, this type of support is twofold. So helping the warrior with the physical tasks they need, whilst helping them to preserve their dignity and independence whenever possible is really, really important. Reminding them that they're getting stronger every day after recovery, because it can take a really long time. You can finish chemo and a year later, you're still rebuilding your body, and that can leave you feeling deflated in so many ways. And then, of course, for the caregiver, just showing them physical affection and care, even on our days where we're able to. Hugs, holding hands, small gestures of physical comfort can go a long way for both of us. There's also informational support. So there's just so much information out there. And as we all know from the time that we were diagnosed, you're kind of on overload. And, during treatment and beyond, there's many, many resources out there, and we just find ourselves under a mountain of pages and things, and we're confused, and chemo brain and exhaustion can kind of set in and take over for those things. So providing informational support can be really, really helpful in taking the load off. So book suggestions, doctor information, recording prescription details. I know that my husband was in charge of my journal. So he wrote down every time I had a symptom and every medication that I took. And that became really handy. And it was a space off of my load too, that I didn't have to keep those records and they were just kept for me. There's also peer support, which, I mean, cancer warriors often say that one of the most helpful and healing parts of their journey and their treatment experience was their peer support. And I can say 100% for me, that was the case. We all say this is a club nobody wanted to join. And as soon as we do, we're just blanketed in love and support from people who get it. We tried symptom, management tactics and ideas and just commiserating together. And it's profoundly, powerful and validating. It can be really distracting too, just to listen to the stories of what someone else is going through and not be stuck in our own heads all the time. There's also spiritual support. So faith can be a big part of the process for many cancer warriors, providing comfort and hope and a sense of community. And of course, lastly, self-support. Making sure that you're practicing some self-care for yourself every day, whatever that may be to you, whatever that means to you, it's different for everyone, but do something for yourself every single day just to try and make sure that you can keep afloat. So then once you're aware of the different types of support, I always say take an inventory of your support because you might actually be surprised. I think of it a bit as like a grocery basket or a luggage bag. You might need just a few essentials, but you might need at least one thing in every aisle. You never know. So you kind of take an inventory of where you're at, and then from there, try to seek out some solutions. As soon as we're diagnosed with cancer, I think many of us are inundated with just message after message after message. For me, the best offers were really clear. I can do this for you, where you can simply accept if you're comfortable. For me, the least helpful was, let me know if you need anything. To me, I mean, that just put the responsibility of not only identifying my needs to another person, but also in this situation where I was already vulnerable. I was exposed. My body was a shell of what it once was. My hair was gone. I didn't look the same. I didn't feel the same. I didn't want to ask for help, and I certainly didn't want to put a searchlight on what I felt like I needed. So that was really, really difficult. And what I did in preparation for this talk is I reached out to as many of my Teal sisters and cancer warriors that I have in my arsenal. I talked with 19 different women about their experience with caregiving and caregiving. And I wanted to share some insights with all of you today. And it was really eye-opening and amazing how much we have in common, but also how many things I was able to learn as well. So the first question I asked them what kinds of support was most useful to them. And resoundingly, 84% of them said emotional support. Other common supports expressed needed were peer supports with 74%, tangible and practical supports with 58%, and physical supports with 52%. And of course, every support has value. And I think that's really important to remember. So less needed, but still valuable supports were 37% informational and 16% spiritual. Sadly, when I asked if they had enough support through their experience, only 63% of my peers did. So as you can see there, honestly, there's still a really great need to jump in and help someone in your life who's affected by cancer. COVID restrictions, not being able to have their support person attend their appointments, or a lack of in-person support meetings left many of our Teal sisters feeling unsupported. Many did not find OCC until later in their treatment, and many more express the need for more emotional support. Because the supports are often found in larger cities, some sisters expressed that it was really difficult to obtain supports in a smaller town as well. It was also said and echoed that during the initial part of the experience, support was plentiful. People are everywhere. I mean, my mailbox was full every day for the first several months. But once treatment was done, the support dwindled and they still needed it. And I second that, because I don't, as we can all notice, it really does dwindle. Those who did get adequate support for themselves during their experience were both incredibly grateful and honestly had better outlooks during treatment and beyond. The next question I asked them was how they went about identifying the supports they needed, and what most commonly came from their cancer care counselor, actually, and advice from other cancer warriors in their lives. Other times, care needs had to reach a critical level before they asked for help directly. And some sisters even expressed they honestly didn't even know what they needed, but they felt unfulfilled. And when it came time to find the supports that they identified, actually, most of us just turned to online search. So Google, local and national cancer agencies, and OCC, Wellspring, Canadian Cancer Society also provided resources. Sisters most commonly used cancer care counselor or posters at their treatment location to help them connect. And some sisters suggested that the information for OCC and other supports should be in a package we got when meeting their oncologist the first time. And I agree, that would have been really, really helpful. Others got their support needs met with church groups before diagnosis that they were involved with, social media, cancer care nurses, peer groups and social workers, their oncologist, and their family doctor. When asked about the easiest ways to obtain the help needed, many sisters actually just said they were comfortable asking for the help. So a lot of them did it directly, some with social media updates or telling friends. And one Teal sister I spoke with suggested that you should identify people in your support network that were good for emotional support and identify people that were good for physical support or some other kind of support. She said that rarely people are good for more than one. So the most helpful offers came in a variety of ways, but most commonly, again, direct offers from caregivers. So I took some excerpts out of what the Teal sisters shared with me, and I wanted to share them with you as well. One Teal sister shared, I had a friend who would say that she was stopping at the grocery store and then would ask what kind of treat I wanted from there. A super direct offer, super great, doesn't leave a lot of pressure on us and is really clear about what they're able to do. Another said, even just asking what foods I'm tolerating right now, offering to go on short walks or pick me up in their car and take me to sit in a park. No pressure, no expectations, just be kind. Another Teal sister said, I found it easier when people offered a tangible help. Example, can I drive you to treatment? I'd like you to bring you a meal. Does this day work for you? It was helpful for someone to start a meal train for me. If someone asked, I could forward the link. I could decide how to respond. I don't have a pet, but some might appreciate offers to walk or clean up after a dog, or pick up a few groceries when they get their own, or cleaning, laundry, or just come for a walk outside with me, or come over and watch a movie together, especially if someone lived alone. And another Teal sister shared, I did not feel up to a lot of company or phone calls, but receiving a card in the mail or a text to know my friends were thinking and praying for my recovery, dropping off some homemade soup or homemade anything was particularly welcomed by my partner. So as you can see, we really appreciate almost any kind of help and support that people can offer. We love when friends and family keep in touch regularly after major treatments, when people asked when it was a good time to call or have a video chat. No matter the support that we needed, it was really important to seek counseling, as many of the supports needed are invisible. There are huge mental and emotional issues that come with this diagnosis and treatment, and they're just as important as the very visible physical symptoms. Another sister reminded me that whilst we always feel that we have to stay strong for those around us, we can ask for help and still be strong. And I thought that was really brilliant and moving. The next question that I asked them what kinds of support were helpful during this time. And the most common response was unhelpful during this time. The most common response was unsolicited advice from those not affected by cancer. Please don't do this. The treatment journey is such a personal one. It's so important that the sister can wade through the decision-making process without feeling pushed or influenced by treatments that they may not be interested in. There is no miracle cure. So please, please, please keep it to yourself. Cancer sisters, we don't want your pity. We don't want your comments. We don't want your suggestions or miracle cures. Some sisters also suggested to me that need to be positive or have toxic positivity was not helpful to them. We have strong days. We have great days where we want to laugh and we want to be positive. And then we have other days where we're not so much. And we love to have that freedom to just be. And that's really great.
Of course, I want to mention finances. They're often tricky during this time, and some sisters express that they had to navigate financial issues to be difficult, and I can confirm this is true. Like government paperwork and other kinds of paperwork are really just, they're a lot to take in, because a cancer diagnosis can come with major financial implications. It would be helpful to have access to a fund without needing to change your financial level. These helps were only available to low-income people, but people in other income levels were not necessarily better off, and the threshold was too low that it became inaccessible to many people. So information about financial support would be one service that would be very useful if people can provide that as an informational support. Others stated that it was difficult sometimes to accept the physical or tangible help because they felt like they needed to be ready to visit, to chat, to spend time, when honestly, all we have the energy for is healing and resting. So the obligation that they felt to be good company prevented them from accepting the help. One Teal sister said, "I found it hard what to say to, if you need anything, let me know. And I never called those people back since the offer was too broad." And that's true as well for me. Even while we're experiencing treatment, we still want to care for our own caregivers, and we want to feel that we are included and that we matter and we're still here. So I asked the Teal sisters how they found ways to care for their families and caregivers during this time. And most respondents chose to have their caregivers spend time without them and with their own family and friends instead as an outlet. Many of us also made sure that their caregiver received counseling to help with the emotional side. And one Teal sister mentioned that her partner took a caregiving course for 5 weeks to help with the effect of providing care and their experience. Some of them got small gifts of thanks, gave social media or verbal thank yous, took the time to remember important events going on for their caregivers, such as birthdays or appointments or other milestones. For those sisters with spouses, they took the time to ask how they were, to check in. Some ordered in food they liked or showed physical affection when able, planned small outings to favorite spots. Many spent time on their best days during treatment to cook dinners, treats, cleaning, helping to relieve the responsibilities of the caregiver. However, more than one Teal sister stated that they often felt like a failure for not being able to provide in the ways that they wanted to their children or partners. And so, as you can see, Paula, we also want to care for our own families and caregivers, and this is really important to us. We know the toll this illness takes on them too, and we want to be productive and useful. And caring for my family is such an important part of my life, and I'm just wondering if you have tips and suggestions on what we can do to be a better support to them too.
Oh, thank you, Victoria. I love that you have just incorporated all these other voices. And I think if we both ended up crying by the end of this session, we haven't done a good job. I guess, I mean, just briefly before my marks, I think that I didn't realize until I was preparing for the session, how much, in fact, Lindsay does care for me without actually articulating those things. But I have learned to have to care for myself. And everyone's like, "Oh, you have to take care of yourself." My family doctor is like, "How are you doing?" "I'm okay." He's like, "Well, take care then." That was the end of it. Cut, print, that was it. I'm like, "Okay, I'll figure that out, won't I?" So I've kind of figured it out, sort of. This is how I figured out. I'll share it with all of y'all. So in terms of caring myself, the phrase that runs through my head the most is the one from the movie Jaws. When the hero, when he sees the giant shark, he says, "You're going to need a bigger boat." And that really reminds me, says, like, you might think you know sharks. You might think you know caregiving, because I thought I did. You might think that your spiritual, emotional boat is sturdy enough to weather any storm. But preparing, like even caregiving for my mom in the past and caregiving for my husband now, did not and do not prepare me for supporting my sister, because she's different, because each of these cancer opportunities are different. So metaphorically and in real life, I have needed to be stronger, find different allies, use different tools, and constantly change strategies as Lindsay's journey has progressed. And I've needed a bigger boat. So what and who goes in the bigger boat? Well, let's start with the easy stuff. a whole lot of chocolate for sure. That's definitely doctor prescribed. Cat videos, we got those. My old yoga mat, a friend who calls me on my crap, an aunt who thinks I'm amazing even when I'm at my worst, and I can get worse. You know, a really noisy country playlist, my hiking poles, a little quiet patch of forest, and that little back corner of my garden where even my neighbors can't see me cry, because you need a place to cry. Because sometimes crying in front of your Teal sister, they don't want to see it. They can't. They don't want to see you cry. Sometimes they can, sometimes they can't. So my bigger boat is also stocked, not just with stuff from the outside, but with new memories and new stories. These, I think I talked about these since cancer, these now stories, those Zoom interviews. They are a treasure. They are such a treasure to me. And pictures of the so when Lindsay had her surgery, we filled her room with these buckets of Costco roses, and there's wonderful pictures of Lindsay. Another is a favorite picture of Lindsay when she lost her hair after she first had chemo, was at my house, and I tied a bandana around her head because of course we didn't have anything else because it was Christmas time. And then we went to see a terrible movie, and I have this wonderful picture of her like lying back in this movie chair with this bandana. I love that picture, and it raises my boat, it fills my boat. But more broadly and more metaphorically, I need to make physical and mental space in my boat for a number of things. So space for actually new skills and new projects, new hobbies, new interests. And this is counterintuitive. You're like, I don't have time. I don't have time for this. I'm busy. But caregiving feels like contraction, or it does to me. It feels like dancing as fast as you can to ward off death. Like, it's like I've got this. People don't die on me. Please don't give me a plant. Like, don't give me a plant. I can't, just don't, I can't. And expansion or growth is healing. It is for me, and it serves as an antidote to those inevitable feelings of impotence, which I think every caregiver has had at some point in time. I need space in my boat for both humor and anger. And both of these are okay. It's okay to laugh and it's okay to be mad, even at your Teal sister. And these do not mitigate your dedication or your love as a caregiver. Lindsay is still allowed to drive me nuts, and I'm still allowed to say so. Oops. And I've needed space for both hope and fear, and certainty and panic, and the understanding that Lindsay and I are going to be at different spaces at different times, and this is going to feel out of tune for both of us. It just is, unfortunately. And I've needed space for grief, for anticipatory grief, grieving in advance. Even though, Lindsay hopes she's going to live 40 years, God willing she will, but I've got nothing to do with that. I can't do anything about that. So, but there is grieving. We've talked about that, as well as mourning the death of my old self, because I've mourned the death of being a daughter. My role as a wife is changing, and my role as a sister is changing, kind of all in this very short time period for me. But I think that love and loss and bearing witness to pain, all this does and should leave scars. And I said to one caregiver once, this shit is hard, and it's okay that it's hard. So I've needed space in my boat to feel the feelings and to get used to the shape of my new emotional body. And it has some open wounds on it still, and it has some healed scars as well. And finally, space for the ebb and flow of power. So caregiving also often involves coming to a new place of power and responsibility. So Lindsay, particularly because the autism, relies on me a lot for medical advocacy and accompaniment, best that I can. But it's also a place of frank powerlessness. I have no control over Lindsay's cancer, like none. I'm going to need a whole arc for that sentence alone. But I can alleviate some of her suffering and also some of my own. Because I think suffering as a caregiver emerges primarily from forgetting. Suffering emerges from forgetting that she's still my sister in all her glory, goofiness, driving me bonkers, worrying me to death ways that she's always been. And if suffering emerges from forgetting, then caregiving or healing of a sort, even if we dare say that, can emerge from remembering, from letting Lindsay in, because I'm really bad at that. I don't let her in. From just texting her that tonight I'm grumpy, I'm overwhelmed, I'm eating chocolate and I'm watching 90 Day Fiance, so don't judge. And having her text back, yeah, you have a lot on your plate. I mean, that's everything. That's still possible. And that makes me feel like I might weather the storm and that I might guide her safely home. Thank you so much.
Thank you both for that. And yeah, I had tears and I had laughter, and I thank you so much for sharing all of that raw and emotional support needs and how to care for yourself and your loved ones. We talked about this before, and this is definitely a session that we knew we needed more time for. So good news is we are going to work on a longer session for our speaker series coming up in the new year with both Victoria and Paula. I just wanted to run through a couple of the comments that were left in the chat box. I'm not sure if you had a chance to read it. There was, I love that storyteller as a caregiver and caregetter, such an important role. Any thoughts or any comments, I guess, Paula, on how do you go about starting that?
Thank you. I think it really depends on who your Teal sister is. This was a surprise to me. Lindsay can be, when she's done, she's very quiet. She can be kind of really monosyllabic. And my husband's like, you're going to get 2 words out of her. I'm like, I'm going to interview her. I put my anthropologist hat on. I'm going to interview Lindsay. And it took a lot of preparation. I didn't give her any questions in advance because I knew she'd want to write down the right answers. And I set it up for her, like for us, because we do this Sunday chat. We have breakfast together. We chat about like everything Sundays, important stuff, stupid stuff. And for her, I had to recreate that setting for her that was going to be comfortable as best as I could, even though it was on Zoom and she's not super comfortable with the technology. And we did a couple of dry runs of the technology as well. So it really depends on how your Teal sister, if you could do it in person, that's great. We also did it in smaller segments because it's a lot. I mean, it's a big journey. There's a lot of stuff. There's hard stuff, happy stuff. And allow it to happen organically if you can. And in, like I said, in the manner and the pace that she wishes when she's ready, not necessarily when you're ready as well. And also don't write yourself out of the story is what I would say.
Thanks, Paula. And I guess just starting. Just
start it. There's no right, wrong. I mean, do pictures, do pictograms, write colors, get some crayons out. You don't have to sit there and write up some, dissertation on the subject. It's your story as a Teal sister, and tell it to someone who you trust, or write it yourself if you are comfortable doing that as well.
Thank you. Victoria, I also just wanted to share with you, we had some other great advice and tips in the chat, and I wanted to share some of those as well. But I wanted to say, I loved the line when you said, you can ask for help and still be strong. That really resonated. I noticed in the chat as well. And I also just picked up on, I love that someone actually asked about your dietary needs. And it really made me think, when I'm being a support person, I got some great tips and advice as well. So some of the women had a laundry fairy. One lady had a laundry fairy for over a year. It was a wonderful gift. She came every 2 weeks. Tim Hortons drive-by. So they'd go to the Tim Hortons drive-through and then just stop by and drop it on the doorstep. Also, one thing I didn't know, but some hospitals sell parking passes, and those can be great gifts as well. Another laundry fairy, a neighbor showed up with 2 laundry baskets, unannounced, didn't tell. lady said that was the best. A couple other ones here was a morning gift. Every morning they would wake up and it would be there, and it was just such a cheerful way for them to start the day. Anyway, we are a little bit over time, but I want to thank you both so much again for this real and emotional conversation. Some great practical advice and tips. And thank you again, and we'll look forward to the longer session come the new year.
Thank you so much for having us, Steph.
Thank you so much. Enjoy the rest of the evening.
I would now like to introduce you to my colleague, Meg Goff. She is the Marketing and Communications Manager here with Ovarian Cancer Canada. Welcome, Meg. I'm going to let you take it away.
For sure. So thank you, Stephanie, and thank you everyone for being here today. I am joined today by Julia in Montreal, Melanie in Halifax, and Starla in Saskatoon. These women were all enjoying full lives, careers, and their families when they were each diagnosed with late-stage ovarian cancer. This disease is unfair, but Ovarian Cancer Canada is determined to make change a reality. Improved outcomes are possible, and a brighter future is within reach. As part of our year-end campaign, our year-end fundraising campaign, these incredible 3 Teal sisters stories will be shared in a letter and emails to supporters on social media and on our website. And our ask is that people read their stories, share their powerful words, and inspire your networks to donate during the giving season to help fund research into Ovarian Cancer Canada and programs that support Teal sisters. So first up, I want to ask Julia, why do you want to share your story with others?
Hi, Megan. Well, thanks for having me tonight. Megan, actually, for so many good reasons, but I actually did a top 3 that I put on my vision board. So the first reason why I want to share my story is to give hope. I have to admit that in the fall of 2020, when I was just diagnosed, I didn't have much hope. I was really sick at the hospital with an advanced cancer, plus I didn't have an optimal surgery. So that means that I still had residual disease after my surgery. But the good news is that today I'm still here, considered stable, no evidence of the disease. I have a CA-125 that is still in the normal range, and I'm not done fighting. So that's the good news. The second reason why I want to share my story tonight is to show people that we can actually live with cancer. We can actually live with adversity. Looking back in my past 2 years, I realized how I lived beautiful experiences. I actually did 1 bucket list trip with my brother, 1 bucket list trip with my mother. I actually got married as well. I was about to forget about this one, but I got married. And I was lucky enough to become the godmother to a beautiful little girl called Julia that was named, after me, and that was born 2 days after my birthday. And the third reason why I want to share my story is because I want change. We all want change, and that's why I'm here tonight. I still feel very frustrated that ovarian cancer doesn't have the same visibility and the same funding as other cancers, such as breast cancer, prostate cancer. I want to see research continue to progress, and I want to see research continue to evolve. And that's why it's important for me to be here tonight.
Awesome. Thank you. And Starla, I want to turn it over to you. One way you've shared your story is on social media, and you've spread the realities of an ovarian cancer diagnosis on social media. And what have you found the power of social media awareness to be?
I think that especially in the last few years, social media has really taken off as a way to connect with one another. And when I started out sharing my story on social media, it was just to be able to really raise awareness and to use it as a teaching tool as well. And I found it to be really successful in that I'm able to connect with all types of people from all over the world that are maybe going through something similar, or maybe they've gone through what I've gone through. It's nice to just be able to connect with even those that are newly diagnosed and being able to kind of give them not necessarily tips and tricks, but just kind of be that person that they may need, just someone to talk to really in that support.
That's awesome. And we mentioned that all of the stories, your stories will be shared on social media. So if people follow along on Ovarian Cancer Canada on Facebook and Instagram and Ovarian Canada on Twitter, then the people will be able to share your stories with others as well, which is really exciting. Melanie, you know, a big part of this campaign is that we want people to donate because we want to progress research further. And what does it mean to you when someone donates specifically towards research? Oh, you're muted. There you go.
I just realized that I was starting. I do that all the time. You think by now I'd be used to that. So for me, donating and donors that are contributing to cancer research and ovarian cancer research specifically, I think bottom line is just it's hope. So we know we're all very familiar, and we all know very well that ovarian cancer is a sneaky disease. And for many of us, it isn't diagnosed until the later stages of the disease, and it really never goes away. So I know that doesn't sound all that helpful, but donations to research means new ideas, new discoveries, and new treatments. Researchers are designing studies aimed at reducing treatment-related toxicities and improving outcomes, meaning longer survival and better overall quality of life. So donation supports Ovarian Cancer Canada's efforts in bringing researchers from across Canada together and collaborate and share their experiences and expertise, as well as their research findings to go farther faster. So there's been a lot of recent advances, a lot of reasons to be hopeful, but we know there's still a lot more work left to do. So to our donors and folks that support Ovarian Cancer Canada, again, it allows us as those dealing with ovarian cancer and our families. It gives us more time with our children, more time with our family, more time with our loved ones. And it helps build hope where not that long ago, there wasn't a whole lot of hope to be had.
Yeah, and I think one thing that I found really interesting when I joined the ovarian cancer team is that just 25 years ago, there were only 3 scientists dedicated to the study of ovarian cancer. And now, because of Ovarian Cancer Canada, the community is 250 strong and growing. And there's some of the most collaborative scientists in the world. And, you know, every donation, no matter how small, how big, goes towards those scientists. And the next big breakthrough could be around the corner because of your donation, which is so exciting. Melanie, speaking of donors, I just wanted to ask if you could say something to our donors who are giving, who might be on the call today. What would you like to say to donors?
I think the easiest, quickest, it's just thank you. Again, like I said, it's about building hope and giving those of us and our families that are confronted by this disease and our loved ones more time. You know, and I know a lot of the women I've spoken with and some of the conversations over the last couple of days, it's like, if I could make it one more day, then there's maybe that next thing that maybe there is the cure, maybe there is another treatment that can help me make it one more day. And it's living for today and being hopeful that we'll have more tomorrows.
That's so great to hear. Julia, you know, one way that people can support is to become a monthly donor. And if somebody does become a monthly donor right now, their donation will be doubled, which is really exciting. And they can do that at ovariancanada.org/brighterfuture. That's my plug. But Julia, if somebody becomes a monthly donor, what does that mean to you?
Means the world to me. A bit like Melanie said, it would give me hope, more hope, and there's never enough hope, honestly. It would give me the chance to just be able to dream of a future, of a brighter future, of a longer future, and that's a lot. So I would say thank you as well.
That's awesome. And Starla, quickly, we're running out of time, but you've been amazing. You were on the symposium yesterday as well. And why do you want to share your story with others?
I think that for me, the reason why I really wanted to start sharing my story is because when I was diagnosed in 2010, I was in my early 20s. And, going through chemo and all that stuff, I just wanted to see my face when I was having chemo. When I sat in that chair and I looked around the room, it was all older people. There was nobody in their early 20s. It was just me. And I think I would have given anything just to be able to sit down with somebody that was my age and be able to talk with them about what we were going through, losing your hair, the loss of fertility, all that type of stuff that, any Teal sister would go through, but I just desperately wanted somebody my own age to be able to connect with. And so through sharing my story, I hope that I'm able to be that face to somebody that maybe is younger, newly diagnosed, and is able to look and be like, hey, like I'm there now, like I'm going through that. And yeah, I just want to be that person that I was looking for when I was going through the treatments.
And I think there's probably with, 500 people registered, somebody is going to have seen you today and yesterday and see themselves in you. So thank you for being here. And thank you to all three of you, Julia, Starla, and Melanie, for being here with me today. And thank you to our donors and our supporters as well. Ovarian Cancer Canada is driving research further, faster, and leading an international movement to galvanize Canada's ovarian cancer research community. And that's all thanks to you. So to ensure this progress continues, please consider making a donation, and you can do that on our website now at ovariancanada.org. Thank you so much.
Thank you, Meg, and thank you, Mel and Julia and Starla, for sharing with us and with everyone, and thank you for your advocacy. I also wanted to just say that Dr. Keats will be also speaking at a speaker series with us in December. So always giving back and sharing in the community. The title of that speaker series is The Evidence on Movement and Exercise for Ovarian Cancer, What Will Work for You? So tune into that one. Marianne will put in the chat some more information about that. So that, Meg, also was a perfect segue into our last session of the evening. You heard it yesterday from our CEO, Tanya, that we truly are on the cusp of breakthroughs that can change the face of this disease. The momentum that's been created in ovarian cancer research is unlocking new insights that can change the face of this highly fatal disease, offering women new treatment options, creating international recognition for Canada as a leader in pioneering transformative research and discoveries. The next speaker, our last speaker of the event, needs no introduction. Dr. Barb Vander Heijden serves on the board of directors of Ovarian Cancer Canada. She is the chair of the research committee. She chairs the OVCAN Governing Council. And Dr. Vander Heijden is with us here tonight to share some updates and highlights of research that's underway and the vision for research going forward. Welcome, Dr. Vander Heijden.
Thanks, Stephanie. And I have to say, as I've sat here for the last couple of hours listening to the stories, some are incredibly painful, and I was really cheered by the last few Teal sisters who talked about the hope they place in research, and I'm hoping the story that I have to tell will provide the hope that many of you seem to be looking for. It certainly has been the most exciting time of my entire career, and largely because of what Ovarian Cancer Canada has achieved just in the last few years. Alicia? So my talk will cover a few points. Very briefly, I will cover how did we get here and what is OVCAN. Most of you have probably heard about this already, but just for those who have not, we'll just cover that briefly. And then we'll spend a little bit more time talking about what OVCAN has achieved so far, and then just a slide or two on what we are thinking about looking forward. So how did we get here? A lot of it had to do with advocacy. And so you see here some of the pictures of the years, the 4 years actually that many of us spent with the patients, the researchers, OCC staff, spent on Parliament Hill or meeting with MPs or giving tours in our labs to try to impress upon our politicians that there was great need for more research in this field, and that the funding mechanisms that existed at the time were not sufficient to provide the funds that were necessary for us to make major advances. And thanks to lots of volunteers who helped with the advocacy efforts, online letters, 4,000 online letters, 13,000 signatures. You might probably already know that the 2019 federal budget included a $10 million investment given to Ovarian Cancer Canada for the sole purpose of advancing new treatments for ovarian cancer. This is huge. It's unparalleled. Never in the history of Canada had we had such excitement and opportunities to move the needle for the treatment of ovarian cancer. So what is OVCAN? I played a big role in actually choosing that name because I think it's powerful and it's positive, and it conveys the kind of hope, the OVCAN, not only for ovarian cancer, but just Ovarian Cancer Canada, but also the CAN suggests that there is lots of possibilities here. And so we established a number of research priorities, that 3 of them specifically, that would cover the gamut from bench to bedside. And so the first one is research models. Now, research models are tools that we use to test new treatments. And the better tools we have, the better models we have, the better they translate into how patients might respond to those same treatments. So we need good models, we need effective models, and we need a variety of models that represent the different subtypes of ovarian cancer. The second priority are the novel treatments themselves. If we have good model systems, then the best thing we can do with them is to take the best ideas from the Canadian scientists and those from around the world and test them in those model systems. Do they work in ovarian cancer? And so that was the second priority, bring those best ideas into the model systems. And the third then is anything that had promise, bring that as quickly as possible into personalized clinical trials to try to ensure that the best ideas and the best new discoveries could be put into clinical trials for the benefit of ovarian cancer patients as quickly as possible. And of course, the whole outcome of this would be hopefully improved outcomes for women with ovarian cancer. And this is a cycle, because if we learn something from the clinical trials that work, that's great, because we can have OCC use its advocacy efforts to get it into approvals as quickly as possible. And if it didn't work, it feeds right back into the research pipeline so we can figure out why it didn't work and how can we improve it to make it happen better. Our third objective is to describe what we have achieved so far. And there is so much, and I wish I had an hour or more to tell you all about it, but we'll just cover some of the highlights. So in priority 1, we view the research models as essentially a toolbox. The scientists are creating a collection of model systems that come from patients, that come from animals, that come from various systems. And we put that into the toolbox. And that toolbox then we would like to share with scientists across the country. And so our goal is to establish a set of what we call gold standard research models that we can put into that toolbox, that a scientist in Montreal can be doing an experiment on the same models as the one in Toronto and the one in Vancouver and the one in Ottawa. And that way we can compare notes and we can say, okay, this model system responded well here and here, but not here. So let's focus on the ones that work. So we have funded 25 projects on ovarian cancer research models, and these they'll fill the toolbox and will set the stage for the future discoveries for new treatments. That toolbox includes all model systems. The priority 2 is the testing of novel treatments in those preclinical studies that will use those model systems. When I proposed to Health Canada what we could achieve, I looked at the budget and thought, maybe if we're lucky, we can develop up to 8 novel treatments so we can test them in these model systems. But in actual fact, OVCAN partnered with IRACOR and the Cancer Research Society, and we're able to fund 13 of very high quality studies where we are testing 13 different treatments approaches for ovarian cancer. We don't yet know whether they'll work or not, but we're going to have those answers in about 1.5 years. That's when those studies all need to be finished. And at that point, we'll be able to see which of these treatments have the most potential and can we move any more of them into clinical trials. The third priority is exactly that, the early phase clinical trials. And again, when we originally proposed to Health Canada what we could do with that $10 million, Well, we thought maybe 4, maybe 5. Clinical trials are expensive, and that's the most we thought we'd be able to fit. But again, with partnerships, we've been able to fund 6 early phase clinical trials, and all of them have what's called built-in translational studies, meaning we're taking samples from patients during the various stages of their course of treatment so that we can see at what point does the treatment fail and why. If we have that information, if we have the tissues to work with, we can determine why something is working, but equally importantly, why something might not be working. These trials were approved by an international review committee. We had to have, because there's so many Canadians involved in this work, we had to have an international panel come in to review the clinical trial proposals, and they chose the 6 that they thought were the most promising. More than 331 Canadians are anticipated to be involved in these clinical trials collectively. So we have we have 6 trials, and they're in various stages. And so the one listed in the first panel is still in the preparatory stage. This was one of the ones that was most recently approved, and so they're still gathering everything together and putting the pieces in place so that they can launch this trial. This is a combination trial of what's called a MEK inhibitor and an anti-estrogen, and it's our first trial in low-grade serous ovarian cancer. This was a coup because trying to do clinical trials on rare subtypes of ovarian cancer is extremely challenging, in part because patients are spread across the country, and to try to be able to do that trial required a coordination of effort. And you can see that the number of sites for that trial includes, there's 6 different sites in 5 different provinces. And that's how big you have to make it in order for enough low-grade serous cancer patients to be included and to make the findings valid. So that will target about 20 to 40 patients. The second one that was also recently approved is also in the preparatory stage. It's a neoadjuvant trial putting together a PARP inhibitor called olaparib with other types of treatments. And again, this one's for high-grade serous cancer. It's being led by Dr. Yvette Drew in BC Cancer, and it aims to target between 40 to 60 patients. And they're trying to recruit the additional sites now so it can be held as much across the country as possible. The one that is ready to go and is not yet recruiting, but should be recruiting either this month or starting very soon, is a phase 1 trial on a combination treatment, again with olaparib and another drug called navitoclax. This again will be for high-grade serous ovarian cancer. It's called the ES2 trial. It's run by Drs. Diane Provencher and Helen Mackay, who are oncologists in 2 different locations in Quebec and Ontario. So there's 3 sites in those 2 provinces. The goal is to target 30 patients, and we're hoping that's going to get rolling very soon. We do have another one not yet recruiting, but is aiming to open very soon. It's looking at the genetic profile to determine the treatment for patients with ovarian cancer who previously received a PARP inhibitor and then became resistant. And so this is an important trial because PARP inhibitors have been a valuable asset to the tools that we have to treat ovarian cancer, but many women will develop a resistance, and we need to understand why. And so that's what this trial will try to do. They aim to have up to 100 women with high-grade serous cancer be included, and they will be obtained from 9 different sites from 4 different provinces. And as I said, we're hoping to get that started very soon. One trial that is recruiting is also based in Toronto, Dr. Amit Oza, and it's a combination study with a drug called CX-5461, and that is again in partnership with PARP inhibition in patients who have the susceptibilities that might usually make them responsive to PARP inhibitors. They aim to treat 20 to 40 women with ovarian cancer, and this is all types of ovarian cancer. And at this point, they're recruiting in 2 sites in Ontario and Quebec. And the final trial is actually already completed in terms of recruitment. It's close to recruitment, and the data is now being analyzed. And this was a study on olaparib given prior to surgery and chemotherapy, as opposed to the normal course now, which is after surgery. Olaparib is often given as a maintenance therapy. But this trial attempted to see if upfront treatment with olaparib would be even better. This is based in Toronto as well with Dr. Stephanie Leroux and Amit Oza, and they have treated up to 71 women with high-grade serous platinum-sensitive recurrent cancer, and that was done on 5 sites in 3 different provinces. So I think the take-home message from what we have achieved so far is, whether it be model systems, preclinical trials, or clinical trials, we've worked very hard to ensure that it wasn't just high-grade serous, although that's important because that's the majority of the cancers, but that everyone who has rare cancers also can see themselves on this map. Our model systems include all of the subtypes. Our preclinical trials includes treatment strategies that we hope will work on all of the subtypes. And the clinical trials are mostly high-grade serous, some endometriosis, and now we've endometrioid, and now we've opened the low-grade serous trial as well. So that's harder to do, but we're working very hard to try to make that happen. I think I love this slide because it's all the faces of the people that I love to work with. Scientists in this field, researchers in this field are the most collaborative group on the planet. That's for no reason other than we recognize the need, and there's not enough of us to be competitive. And we are all of the personality that we know that if we work together, we can achieve far more than trying to be competitive with each other. And so researchers across Canada are being funded, and you can see their photographs there. I don't need to name them all, but I can tell you that this is one phenomenal and dedicated group of individuals. So OVCAN funded projects are addressing what we think are the important clinical challenges in ovarian cancer, keeping in mind that the original goal for the funds was to do our best to advance new treatments for ovarian cancer. I recognize, and the conversations we've had already earlier this evening would indicate that there's a lot of other issues that need to be addressed. OCC is working on those and is working on obtaining additional funding, or hoping to obtain additional funding to address some of the other clinical challenges that women with ovarian cancer face. But one of the interesting, this is again, an example of how the effective treatments for rare types of cancer are being studied across the board. And so we wanted to ensure that individuals who don't have who have the less common types of cancers will see themselves. And we've actually funded 13 different projects that total $2.2 million that fuel the discovery of the less common types of ovarian cancer. And you can see them listed there. The clear cell endometrioid, we have priority 1, priority 2, and priority 3 projects that are trying to cover as many of those subtypes as possible. I think one of the most interesting stories we have about the toolbox is there was very little to work with if you wanted to test a novel treatment on low-grade serous ovarian cancer. The model systems were just not there, and what was there was not very well characterized. And so we put a lot of money towards having a number of groups, and particularly the group in Vancouver under the leadership of Mark Carey, taking patient tissue from women who have low-grade serous, establishing different model systems, 2D cell culture, 3D cell culture, PDX. I don't have time to describe that, but happy to answer questions about them if you wish. Characterize them at a level that is down to the molecules, down to what is going on inside the cells, and seeing if that information can help predict what drugs might be effective on that particular type of cancer. And so drug sensitivity becomes part of a cycle where we look at the molecular characterization, we test drugs that we think should work. If they don't work, we find out why, and then we go back and try to improve the drugs that we have that are effective for that cancer. And so it's a really important set of model systems, and it's one of the greatest achievements, I think, in our research toolbox. So, and this is a perfect example of it. So you can take some of these model systems and then try different kinds of treatments. And you don't need to know about the treatments. One's called a MEK inhibitor and one's a RAF inhibitor. But you can see that the control, this is the tumor growth. So the tumor volume is getting bigger as you go up to the right. And you can see that the controls that are not treated, oh, thanks, Alicia, that you can see the tumors are very big. If they're given the tumor, the animals or the xenografts are given RAF-I, it works a little bit, but not very much. But if you use a higher dose of RAF-I, you get a better response of tumors not growing as much. And especially in the green, if you use a RAF-I and a MEK inhibitor together, look, the tumors actually don't grow at all. So in this model system, it predicts that the combination treatment of a RAF inhibitor and a MEK inhibitor might actually be very effective in stopping tumor growth in women with ovarian cancer of this type, of low-grade serous ovarian cancer. So it's very exciting. This data is all very new. They just published that data about a month ago. So it is very exciting. Okay, so one of the challenges with ovarian cancer is, unlike many other cancers, immunotherapies, which are the sort of the hot new treatment in the cancer world, don't work on most ovarian cancer patients. About 14% of ovarian cancer patients will respond, which is much less than, let's say, 46% of melanoma patients. And so the question is, why not? And one of the obvious answers to me is that we don't have model systems to test immunotherapies for ovarian cancer. If we don't have those model systems, then we can't test new immunotherapies. We can't just be giving it to women without having it go through model systems first. So we have funded 13 projects that total $2.4 million specifically to address what are the immune targets that are present in ovarian cancers and what new immune therapies can we develop for ovarian cancer. So why is it important and why is it challenging? Well, we talk about ovarian cancer as if it's a bunch of cancer cells. It is that, but it's also a bunch of immune cells of all different sorts. It has other cell types as well, blood vessel cells and fibroblasts and stromal cells. And the immune cells, when they are attracted to the cancer with the intent of trying to kill the cancer cells are very tricky, and they turn around and say, no, you can't see us. They suppress the immune cells so that the immune cells can't do their work. And this is really annoying because it means that if we give an immunotherapy, the immune cells are sitting there going, I don't see it. I don't see the cancer cell. I'm not going to do anything. And so we've got to find a way to wake up those immune cells so that they'll go ahead and kill the cancer cells like they're supposed to. Jeanette Boudreau is a scientist at Dalhousie. She's an amazing immunologist. And she said, there are the subset of patients who do respond, but we need to learn more and more about the immune context of ovarian cancer so we can improve the immunotherapies that are available to them. Okay, so this actually comes from my lab. If we want to test immunotherapies, we have to have a model system that has an intact immune system. As I said, we can't test this on humans, so we use mice. So we start with a mouse that has ovarian cancer. We take the tumor out, we put the tumors in addition, the cells will grow. Then we take those cells, we put them back into mice, and now the tumors will grow in what's called a syngeneic model. It's a mouse that has all of its immune cells present, plus it's now growing a tumor. So we can use that as part of our big toolbox to test novel immune therapies. So we've done this, and we have a number. Our toolbox includes 1, 2, 3, 4, 5 are shown here. 5 circles would indicate that we have 5 different model systems in our toolbox. And the color wheel is just showing you all the different kinds of immune cells that are present. And you can see right away that the colors, abundance of the colors, are different in every single model system, which is really great because women with ovarian cancer don't look the same way, and neither should mice. And so we have a nice collection of model systems, each of which has a different kind of ovarian cancer with its own collection of immune cells. It's a perfect setup to be able to test novel immunotherapies in all of these different model systems. Okay, so looking forward, where are we going to go with all of this? Well, we're wrapping up, actually, we're the last year and a half of that initial 5-year allocation of federal funds to Ovarian Cancer Canada and the OVCAN initiative. So we can't be sitting around waiting for something to happen. OCC is always on the ball. It's already begun its lobbying efforts. At the end of September, we had a lobby day on the Hill. Some of us were there in person, but many, many people across the country were participating. The scientists, the OCC staff, patients, really selling the importance of keeping this work going. We have made such tremendous advances in just a brief period of time, and it's now time to ensure that we don't stop, that we continue this momentum. And so I'm very excited by what we've achieved, and I'm even more excited by the opportunities that we can take even more into the patients, into the clinical trials in the years to come. I do have to thank a lot of people. OVCAN is not, I mean, in addition to Health Canada, which got the ball rolling, the provinces of Saskatchewan and Nova Scotia each contributed $1 million to the OVCAN initiative, which I think is fabulous. I think other provinces need to step up to the plate, but maybe got sidestepped a little because of COVID. But now it's time to go back to them and make sure that they contribute their portion. And particularly IRACOR and the Cancer Research Society have been wonderful partners in ensuring that we can maximize the amount of work that we can do with the funding that we had. The second group that clearly needs a lot of gratitude from me and from everyone involved in OVCAN are the patient partners. We have the patient partners and research team. This is the group that actually came to the Canadian Conference on Ovarian Cancer Research back in May, which was here in Ottawa. And these women have been phenomenal at participating in every single aspect of OVCAN work. They are serving on the grants panels. They are advising us. They're on the governing council. They are telling us what we should and shouldn't do at every step of the way. And we are doing our best to listen to them because they're the ones who are experiencing this disease. They have the lived experience, and they're the ones who need to tell us what they want us to fix, and we'll focus on that as much as we can. So I do want to thank all the patient partners in research. I think you're all amazing women, and you motivate us every day to do the work that we do. So thank you.
Thanks, Barb. It's always so great to hear from you, and the passion that you have for your work just comes right through the screen. So thank you for that. And thank you also for sharing those exciting updates with us tonight. We don't have time for any questions. There was a couple in the chat, so we'll connect after and get the answers to those, and then we'll share those out with the unanswered questions from the other sessions.
Okay.
So that concludes our National Fall Symposium. I laughed, I cried, and I don't know about you, but I'm leaving tonight feeling inspired and revitalized. I want to extend our sincerest thanks to all of you who have shared your knowledge, your expertise, your emotions, experiences, and your powerful personal stories with us over the last 2 days. We are truly grateful. I would also like to once again thank our sponsor, GSK. And finally, I want to thank all of you who took the time out of your day yesterday and today to join us for our National Symposium. I hope that you connected with our community, that you learned from our expert speakers. And again, mostly, I hope you were inspired. On this next slide that's coming up now, you are going to see a QR code as well as a link to an evaluation. This link will also be sent to you by email tomorrow with a link to the recordings from the sessions as well. This evaluation is a SurveyMonkey evaluation and shouldn't take you more than 5 to 7 minutes to complete. Your feedback is so important to us, and it truly does help us shape and advance future initiatives and programming. I know that I was furiously writing in some of the chat because we've got some great ideas for some great topics for the next sessions. So thank you in advance for just taking a couple of minutes to fill this evaluation out. And again, that all of the sessions were recorded from yesterday and today. If you want to rewatch, or you were unable to attend a session, or you just want to forward it on, they will be loaded onto our website at www.ovariancanada.org. And also the link will be sent out in the email for tomorrow. So again, from all of us here at Ovarian Cancer Canada, thank you for spending the last 2 evenings with us. Thank you for your support and your confidence in our team. Without you, events like this and the progress would not be possible. I wish you all the best. Take care. And I leave you tonight with some words from our team here at Ovarian Cancer Canada. Good night.
Hello from Toronto. I am so inspired by your passion and your commitment to make change a reality for other women and their families affected by this disease. Thank you for taking part in this symposium, and especially thank you for being a part of our community.
Thank you for being a champion for this cause and for making an impact in your communities coast to coast. We cannot do this without you.
Hello from Mississauga. My name is Heather, and I want to thank you for being a part of the Ovarian Cancer Canada community this year. I am inspired by your passion and your determination to make change a reality for other women and their families facing this disease. Thank you for being here tonight and being a part of our community.
Hi from Montreal. It was so wonderful seeing so many of you at the Ovarian Cancer Canada Walk of Hope. Let's see what 2023 has in store for us.
Hello from Montreal. My name is Jessica and I'm the new research coordinator at Ovarian Cancer Canada. One of the highlights of my year has been meeting so many patient partners in research that are giving patients a voice to drive future patient-centered research. Thank you all for being here tonight. You all are making a difference.
Hi from Barrie, Ontario. Thank you all so much for joining us tonight. I've had the opportunity to spend the past few months working as part of the community engagement and events team with Ovarian Cancer Canada. And being my first year with the organization, it has been incredible to be able to meet some of the community that we're working with across the country.
Hello from Bayfield, Ontario. I just want to say thank you for being a part of the Ovarian Cancer Canada community this year. My name is Kaylee Crawford, and I'm part of the team that works on education and support programming and advocacy.
Hello from Calgary. My name is Meg, and I'm on the marketing and communications team at Ovarian Cancer Canada. It has been such an honor to work with so many of you this year, sharing your stories on our digital platforms, in media, and other avenues. I hope you've had a wonderful evening, and I can't wait to see what the next year brings.
Hello from London, Ontario. I loved working with so many of you to make the 2022 Walk of Hope a meaningful day. It warmed my heart to see so many of you come together to support one another and further progress against this disease.
Hi, I'm Marianne Follis, Programs Associate here with Ovarian Cancer Canada, and I want to thank you for being here with us tonight. Since I joined the team in July, I've had the opportunity to connect with some of you at different programs and events. And I want to say you leave me truly touched and inspired about the way that you build connections.
Hi, my name is Valerie. I'm the Regional Director in Quebec for Ovarian Cancer Canada. Thank you so much for joining us at our National Symposium. I hope this is a wonderful opportunity for you to learn more about ovarian cancer, hearing from leading experts from across the country, as well as an opportunity for you to make meaningful connections with other community members. So I'm wishing you 2 wonderful, insightful, and informative evenings, and hope you enjoy.
Hello from Toronto. I'm Alexandria, and I want to thank you for being a part of the ovarian cancer community. I've been in my role now with Ovarian Cancer Canada for a few months on the Programs and Policy team. And one of the highlights for me as the Government Relations and Advocacy Associate was working with so many of you leading up to and during our successful Day on the Hill at the end of September.
Hello from Amherstburg, Ontario. My name is Tanya Vrionis. Thank you for being a part of this very special community. The impact that you've had coast to coast is immeasurable. We could not do our work without you. It has been such a highlight this year to gather with and meet so many of you in person. From the Canadian Conference on Ovarian Cancer Research in the spring, to our Walk of Hope, to a number of community events led by dedicated volunteers, I've had the pleasure and privilege of meeting so many of you and spending time with you in person, and I'm so grateful for that. Together, I know we will reach our goals and make a difference for those living with ovarian cancer today and well into the future. Thank you for your continued support, and I look forward to seeing what comes next.
And I thank you for being here tonight. I'm excited to continue our work together so we can advocate for the best possible care for every individual with ovarian cancer.
Thank you for being here and have a wonderful evening.